우리 네. 네네네, 알겠습니다. 네네. 중간에 그럼 커피 브레이크를 할까요?
한 명이 팔로워서 시간이
네네.
디스커션 해도
네네.
되는
네네네.
제일 남을까 봐.
아,
사람들이 커피 브레이크가 왜 없냐고 없다고.
네. 음,
아니 디스커션이 핫하냐 그럴 필요가 없고
네네네.
핫하지 않으면 이게 이제 연습대로 있을 때 10시 20분까지인데
네네네.
아마 여기가 아마 10분으로 담으면
아,
뒤집어지 말고
철주 쌤한테 잠깐 말씀 드리고. 네, 시작하겠습니다. Good morning. Good morning, dear distinguished speakers and audience. Thank you for coming to the second National Cancer Center Gastric Cancer Forum today. The first, the Professor Young-woo Kim, the director of the Research Institute, National Cancer Center Korea, will give greetings. Professor Kim, please.
Morning. Thank you very much. Today morning is so cold. It's a totemo samui desu in the Japanese. Although it's very cold, thank you so much for coming to National Cancer Center. And it's my great pleasure and honor to have you all. So although it's just one country, the very close country from Korea, Japan, actually is a globally the most famous leading scientist and researcher and clinician, I think. So it's a great honor and pleasure for us. Today, actually, this meeting is a hybrid type of meeting because it's a very cold winter time, and Ilsan, this area is somewhat far from Seoul, and of course from other areas of Korea. So we have a plan to have a hybrid. So we will use today the Zoom meeting. So I hope many people from all over the country could participate online also, although not so much people here in the auditorium. So I think our meeting today, forum today, will be very, very interesting and helpful for the many people who are interested in the gastric cancer, because the gastric cancer is one of the most important cause of death, cancer deaths all over the world. There's a yearly 1 million new cancer cases, is in the world. So almost over half of the cancer patients are from Asia, and then that Korea and Japan is the highest incidence for the gastric cancer in the world. So it is I think, is a mission and our role and then our responsibility, to conquer the gastric cancer. So far, I think the most important and then great contribution was from Japan. So we all admire and then appreciate that. And then in these days, Korea also doing quite well. And then National Cancer Center, I'm very proud of our colleagues from National Cancer Center to contribute some of part of kind of extending knowledge and information for the gastric cancer for 20 years. NCC was developed almost 20 years ago. So exactly maybe 22 years. Yeah. So I just hope today and you enjoy many lectures and hopefully could communicate closely, and then more hopefully could make some networking and connection for the next collaboration. I think in the future the collaboration is a key, because any single clinician or single scientist or single centers, even centers, cannot resolve this very important kind of problem and then very difficult problems. So collaboration is a key to resolve those problems. So I believe so today must be a kind of good momentum to every people, could have those kind of mindset and then proceed together for the conquering of the gastric cancer together. Okay, so in this small abstract book, you will find our history of this gastric cancer seminar for 20 years, and then this forum was possible because of the cordial donation from many common people actually who are interested in developing the treatment for the gastric cancer. I really thank to them today. And then, of course, support from National Cancer Center, especially President Hong Wan-seo. He really, appreciated and then supported very generously for this meeting, because in these days the flight, air fee was so increased, so we had to raise up the kind of money for this forum. But our president has very contributed a lot and then helped a lot, to increase the budget for this meeting. So thank you so much for that. And okay, so now it's time to start. So first session is a gastroenterology, and second is medical oncology and pathology, and then we'll have in the afternoon after the lunch. We have a special session with the Professor Sasako. Professor Sasako is coming, is flying maybe right now. He will join in the afternoon session, and then he will chair the last session also. So I'm very much looking forward to hear his special lecture for 50 minutes for the history of the clinical trials for the gas cancer. So today we have Professor Masanori Terashima. He was former JCOP chair for many years, and a huge contribution was done by him. But before him, the Professor Sasako was also a chair of the JCOP gastric cancer group, and then it was a really immense contribution for the extending the knowledge and the information for the gastric cancer patients. So we are very proud, and then we are very grateful for the participation of those, of course, in other speakers also, but I'm very happy to have, and then very honored. Okay, I just hope today and everybody enjoy today's session, and then we will have a great fruit, good fruit after the forum. Thank you so much. Thank you.
Thank you, Professor Kim, for greetings for us. Now we will start the first session. The first session is gastroenterology session. The Professor Il-ju Choi will chair this session. Professor Choi, please.
Morning, everyone. My name is Il-ju Choi, and I'm a gastroenterologist and endoscopist in National Cancer Center for Gastric Cancer. This session is gastroenterology session, and I'll introduce the first speaker, Young-il Kim. He graduated Jeonnam National University in 2003 and got a PhD degree 2020 in Chungang University. He was the visiting scholar in Baylor College of Medicine, Houston, from 2001. And his research field is pathophysiology, therapeutic endoscopy, gastric cancer prevention, and artificial intelligence of endoscopic images. The title of today's talk is Clinical Outcomes of Endoscopic Resection on Different Type of gastric cancer. Dr. Kim, please.
Thank you, Chairman, for the kind introduction. It is great honor for me to present here in the NCC Gastric Cancer Forum 2023. The endoscopic resection has been widely performed for early gastric cancers with negligible risk of lymph node metastasis. In previous Japanese Gastric Cancer Association guideline, the ESD for all expanded indications considered as an investigational treatment. Based on the result from Japanese trials, all expanded indications in recent Japanese guidelines became absolute indications. In Korea, the indication for undifferentiated type early gastric cancers, mucosal lesion without ulcer findings, and size less than 2 cm is included as an expanded indication. In a meta-analysis of 12 retrospective studies, a significantly higher lymph node metastasis risk was reported in expanded indications of undifferentiated type. Therefore, in Korean guidelines, the ESD indication for undifferentiated type early gastric cancer was weekly recommended. In the revised Korean Gastric Cancer Association guideline, the recommendation level was changed from weak recommendation to conditional recommendation because of the risk of lymph node metastasis. In National Cancer Center Korea, the undifferentiated type EGC ESD cases had been less than 10 cases per year. Since 2017, the number of ESD for the undifferentiated type early gastric cancer has increased slightly. Since 2018, the cost for ESD for undetype early gastric cancers has been partially covered by the National Health Insurance. This table summarized the guidelines recommendations for ESD for undifferentiated early gastric cancer. The Japanese guidelines recommended as an absolute indication with moderate level of evidence and strong recommendation. However, the guidelines from Korea, USA, and Europe recommended as an expanded indication. In addition, there is no recommendation in NCCN guidelines. Let me talk about the short-term outcomes of ESD for undifferentiated type early gastric cancers. In Korean retrospective studies investigating the short-term outcomes of ESD for undifferentiated type early gastric cancers, the mean or median tumor size was more than 1.5 centimeters. The curative resection rate were between 31% and 70%. The pooled curative resection rate was about 47%. In Japanese studies, the median tumor size was about 1 centimeter, and the curative resection rate were between 64% and 83%. The pooled curative resection rate was about 74%. The curative resection rate were higher than in those in Korean studies. We evaluated the discrepancy between pre-ESD indications and post-ESD criteria. In this study, 660 patients with absolute indications and 96 expanded indications were included. The non-curative resection rate on the final pathological evaluations was 53% in patients with undifferentiated type early gastric cancer, meeting the pre-ESD indication. And the undifferentiated type of histology on endoscopic biopsy was an independent risk factor for non-curative resection. In a retrospective study including more than 500 undifferentiated type early gastric cancer treated by gastrectomy, the investigators retrospectively classified that 280 patients meet the pre-ESD expanded indication. Of the 280 patients, the curative resection was achieved in 42 patients. The main cause of non-curative resection were post-ESD size more than 2 centimeters, submucosal invasion, and lymphovascular invasion. In addition, the patient with undifferentiated type early gastric cancer meeting the curative resection criteria, 3 cases had lymph node metastasis. All these lymph node metastasis cases were observed in tumor size more than 1 centimeter. A multi-center retrospective Korean study involving 450 patients on differentiated type early gastric cancer treated by ESD evaluated the risk factors for lung curative resection. The curative resection rate was 43%. Risk factors for the non-curative resection included the endoscopic size of 1 to 2 centimeters, more than 2 centimeters, and upper third location of a tumor. In a subgroup analysis, according to the endoscopic tumor size, non-curative resection rate was higher in cases of tumor size of more than 1 centimeters. In patients with a tumor size of 1 to 2 centimeters, the non-curative resection rate was 57%. The main cause of non-curative resection was pathologic tumor size more than 2 centimeters. In addition, 22% of cases had submucosal invasion. This is the summary of the first part. The ESD for undifferentiated type early gastric cancer is recommended as an absolute indication in Japan, whereas it remains to be an expanded indication in Korea, USA, and Europe. The curative resection rate of ESD for undifferentiated type EGCs had been reported low in previous Korean retrospective studies. Endoscopic tumor size of more than 1 centimeter was an independent risk factor for the non-curative resection. Next, I'd like to talk about long-term outcomes. A multi-center single-arm prospective study was conducted in Japan. In this study, 275 undifferentiated type early gastric cancer patients underwent ESD. The median tumor size was 1.1 centimeters, and the curative resection rate was 71%. On the pathological evaluations, the main non-curative factors was included the tumor size more than 2 centimeters, 13%, and SM invasion, 12%. During a median 69.9 months, there was 5 death cases, the 4 due to the other diseases, and 1 death after lymph node metastasis recurrence. The 5-year overall survival was 99%, and the 5-year recurrence-free survival was 99%. In the definition of recurrence was local or distant recurrence. There is the recurrence-free survival. In this recurrence-free survival, metachronous recurrence was not included. As a result of this study, the Japanese guideline included the ESD for the undifferentiated type early gastric cancer as the absolute indication. In this study, overall 4 metachronous gastric cancer occurred after 3 years after ESD. The 5-year metachronous gastric cancer incidence was 1%. Of the poor metachronous gastric cancer recurrence, the 3 patients curatively treated by ESD. In Korea, the long-term outcomes after ESD for ESD of undifferentiated type early gastric cancer were compared with those after surgery in a multicenter retrospective cohort study. From 18 hospitals, overall a total of 711 patients with undifferentiated type early gastric cancer meeting the curative criteria were included. After a propensity score matching, the 218 patients in each arm was included in the propensity score matched cohort. The primary outcome was overall survival, and the secondary outcome was disease-free survival. In this disease-free survival, the synchronous and metachronous distant metastasis, local recurrence was included. During a median follow-up of 6.3 years, the 5-year overall survival rate was 96% in the ESD group and 99% in the surgery group. The ESD group had significantly lower overall survival compared with surgery group. However, after propensity score matching, there is no significant difference in overall survival between the 2 groups. Furthermore, the overall survival was not different according to the histologic types, such as signaling cell carcinoma and poorly differentiated tubular adenocarcinoma in the propensity score matched cohort. There were 22 recurrence cases in the ESD group, but no recurrence case was noted in the surgery group. The disease-free survival was significantly lower in the ESD group than in surgery group, mainly due to the metachronous gastric cancer recurrence. In the ESD group, 2 cases developed distant metastasis during the follow-up. A similar result was observed in the propensity score matched cohort. ESD group had lower disease-free survival compared with the surgery group. In the surgery group, the total 6 cases of lymph node metastasis were detected even in tumors meeting the expanded criteria. In guidelines, the section interval of ESD specimen was 2 to 3 millimeters, and for the surgical specimen, 4 to 7 millimeter intervals were recommended. These wider section intervals in surgical specimen might cause underestimation of focal lymphovascular invasion or submucosal invasion. In our study, we performed histological evaluations for 401 EGC specimens in 2 millimeter, and 4 millimeter, and 6 millimeter section intervals. With the wider section intervals, the detection rate of submucosal invasion and lymphovascular invasion was significantly lower compared to the reference 2 millimeter interval section. The underestimation of submucosal invasion or lymphovascular invasion by the surgical specimen is a potential cause for misclassification for curative resection or lymph node metastasis in EGCs meeting the curative resection criteria. Long-term outcomes were also evaluated by a meta-analysis of 5 retrospective studies from Korea and China. The risk ratio for overall mortality in the ESD group was higher in overall cohort. However, in the propensity matched cohort, there was no significant difference in the overall mortality. However, the risk of recurrence increased significantly in the ESD group in overall cohort as well as a propensity matched cohort. In addition, the risk for extragastric cancer recurrence was also higher in the ESD. The ESD group had 5 cases extragastric recurrence, and surgery group had 1 case. Therefore, we have conducted a multi-center prospective open-label randomized controlled trial, ERASE-GC trial, to evaluate the long-term outcome after ESD and surgery for undifferentiated type early gastric cancer, meeting the pre-ESD expanded indication. The study period are between 2021 and 2027. This trial was planned by a multidisciplinary society and have conducted in 9 university hospitals in Korea. The primary outcome of this trial was a 3-year disease-free survival in the ITT population. The secondary outcome include the 3-year disease-free survival in per protocol analysis and overall survival and other short-term outcomes. The total sample size for this trial is 708. Until December 2023, a total of 607 patients were enrolled. The total enroll rate was about 86%. We expected that the completion of enrollment will be in June 2024. This is the summary and conclusions. Long-term overall survival after ESD for undifferentiated type early gastric cancers meeting the expanded criteria was comparable to that after surgery in propensity score matched cohort. However, in a meta-analysis of Korean retrospective studies, the risk for disease recurrence after ESD was higher than that after surgery, including risk of extragastric recurrence. Therefore, more evidence is needed for the ESD of undetype EGCs, including prospective RCTs with longer and standard follow-up. In Korea, the ERASE trial has been conducted to compare the long-term outcomes of ESD versus surgery on D-type EGCs meeting the pre-ESD indication. This trial might provide high-quality evidence to the guideline recommendation. Thank you for your attention.
Thank you for your nice presentation, Dr. Kim. And this topic is now open for the question or comment from the floor.
You first.
Thank you for your good presentation. And I have two questions.
Yeah.
One question is Professor Ann's manuscript, Gastric Cancer 2021, propensity matched scoring ESD case and the surgery case. And they found 6 lymph node metastasis cases. I'm very surprised 4 millimeter signature cell carcinoma, its depth is LPM. That case is an unbelievable case. So the cause of surgical specimen, yes, 4 millimeter number 3 cases. And this is a LPM, depth is LPM. Poor differentiated adenocarcinoma. I think this case is a very interesting 6 cases. And only 4 millimeters and the depth is LPM.
Yes.
It is a very rare cases.
Yeah, thank you for the good question. Actually, we reviewed this case, the surgical evaluations in Korea. Actually, the early gastric cancer was detected by screening endoscopy outside the university hospital. So we speculated that the multiple biopsy already performed at the screening endoscopy, and then we also we checked the diagnostic endoscopy, and another biopsy will be performed. So after surgery, the tumor size is the pathological size.
Yeah.
So we speculated that,
yes.
but the exact cause is not
okay.
remain to be elucidated.
Yeah.
Yeah.
I understand well. And the next question is ERASE GC trial. I think this trial is a very high quality trial, but how to recruit the patient? Patient wants to performing the ESD. How to randomization?
Actually, Professor Che is the PI. In Korea, the undifferentiated type early gastric cancer ESD for the untype EGCs is an expanded indication, not fully covered by the national health insurance. So we fully explained to the patient and their caregivers there is a high risk of lymph node metastasis after ESD. So, however, this is the important trial to compare the long-term outcome for the ESD versus surgery. So, after the fully explanation, if the patient agree to the randomization to the either ESD or surgery, we enroll the patient. However, patient the reluctant to surgery want to ESD. For that patient, we do not perform randomization. Whereas some patient want surgery first. not ESD. There is a very various situation in this trial.
Yes. 3 years follow-up. This is, I think, so short.
Thank you for the good question, but the budget for this trial is limited within 4 years. So we planned the study primary outcome with 3-year disease-free survival because of the budget limitation. However, we will follow the enrolled patient during long-term follow-up. Therefore, we included the overall survival in secondary outcome.
Thank you very much.
Relating to the previous question by Professor Zaki, so what is the rejection rate after the randomization in this trial?
Actually,
the rejection means that patient choose what they prefer, right? So they reject to get randomized as a randomization result. So that is a very important point of this trial, I think. Otherwise, this randomization doesn't have a lot of meaning as a randomization. So can you tell rejection rate?
The rejection rate is different according to the site according to the hospital. In our hospital, we fully explain the situation for randomization. If the patient want ESD, but you could not treated by ESD. If the patient agree, we random. So our institution, the rejection rate is very low, but other site, the rejection, before the randomization, if the patient do not want to surgery, we do not random the patient. However, initial phase of this trial, after randomization, the patient do not underwent randomized treatment. So in early phase, the rejection rate was some high. However, nowadays we do not random the patient.
All right.
Like.
Yeah. Okay. Okay. So I have a question. So I think you showed many data, so kind of retrospective data, but I'm very curious about the how many patients actually lost after the ESD. So almost all data, just included the patient who has a good follow after the ESD and underwent the surgery. So I think it's not a real, world data to show the safety of the ESD. So maybe, some patients, in my experience after the ESD, if the clinician explained the outcome of the pathology and then recommend the surgery, but they are very reluctant to get the surgery, so they just refuse and then disappear, not to have a surgery. So I think it's very important to include all those kind of cases to say it's a safe for the kind of undifferentiated type of the early cancer to be resected by ESD.
Yeah, thank you for the comment. Actually, in a retrospective study, as you mentioned, we cannot follow all patients after ESD. So, like this prospective trial, we can follow the more standard follow-up for the patient after ESD and as well as surgery. So, I don't know exact percentage of the patient follow-up loss, but some studies reported the the patient with non-curative resection do not underwent additional surgery about 3% to 40%. So in some retrospective studies, however, the exact number is not known.
So I think, you know, the gastroenterologist in our country and maybe including Japan, I think it's very important to, you know, to have a kind of registration for the all ESD cases, especially for this kind of very high risk patient. And then you need to do, you know, do a lot of effort, you know, to, you know, include the data. I think it's your kind of responsibility for the gastroenterologists who are doing all this ESD. It's very important. So otherwise, we really cannot know real data, you know, about the, you know, ESD for the undifferentiated carcinoma. And then for the study of the propensity score matching, the only 20% of the whole patients were included. So I think too many exclusions. So maybe it doesn't reflect real data, I think. Anyway, so my conclusion is that my idea is that, you know, we need to be more careful to say it's safe. So we need a more kind of reliable data. That's the reason why you are doing you know, this ERASE trial. I think it's a very important trial, I think. Yeah.
Yes, the high follow loss rate maybe also one of reason is that the patient do not undergo additional surgical treatment in hospitals. The patient underwent ESD and the patient moved to another hospital. So the reason is one the explanation. Yeah. Yeah.
To follow all those patients move to our hospital, we can follow, we should follow, and we can follow. But that's the
Okay, Hiroshima, can I ask one question about the statistics of this trial? I think in JCOG, we are abundant to make the randomized control trial because survival rate is around 98%. So it is very difficult to make a randomized control trial with sufficient non-inferiority margin with sufficient power. How do you think about this issue? I think 700 patients is too little.
Thank you for the comment.
Maybe so. 10,000, more than 10,000 patients we need.
Yeah, thank you for the comment. Actually, this trial is not a non-inferiority trial. Superiority trial, because the primary outcome was disease-free survival. As I showed the data for our retrospective cohort data, the disease-free survival rate was superior in surgical group. So
no. You want to investigate the efficacy of ESD, right?
Yes, but
if so, you have to demonstrate the superiority of ESD.
No. This is the surgical.
Rationale is a little bit strange for us. If you want to show the efficacy of ESD in superiority trial, you have to demonstrate the superiority of ESD. Maybe I think it's the minimum invasiveness of ESD may cause the higher survival rate than surgery, even especially for the elderly patient, I think.
As your comment, the non-inferiority trial is good for compare the ESD and surgery, but there is some limitation of budget and study period. So
if this result positive, so every patient should receive surgery, right? Because the surgery won.
We also the subgroup analysis in patient after the long-term follow-up. In subgroup of patient with tumor size according to the tumor size or some non-curative factors, we will compare the outcomes between the ESD group and surgery group. So some patients should undergo surgery first. However, in subgroup of patient, the ESD can be on a standard treatment for the some subgroup of patient.
If you
Maybe,
think
yeah,
so,
yeah.
the single arm trial is enough.
Single arm
Trial
trial.
is enough. Not, you don't have to randomize patient. I think, yeah, that comment, okay.
This is a very important question and comment. We also know that the meaning of the question. But actually, this trial was designed as a spirit trial for surgery because in Japan, many data suggest that endoscopy is a standard treatment. But in Korea, we have many data that curative resection rate is lower. And even lymph node metastasis is common in this group of patients. So then our retrospective data suggests that almost 100% overall and disease-free survival in surgical group. So actually, Professor Skin mentioned that many patients after ESD are reluctant to get another operation, even there is some non-curative factors. So that might be such a big problem if the proportion is high. So we want to do a randomized trial to check after a randomization, ESD group or surgery group, even after ESD group, after the ESD, some patient was non-curative, and overall patient was analyzed in ESD group. So we speculate that that might cause very poor survival. So in Japan, the standard is now ESD, but we want to show that in this group, in Korea, standards should be surgery, especially in probably larger tumors such as 1.5 or 2.0 centimeter, relatively large with So we designed it should be the spiritual in Korean situation, but the title might cause some problem to understand fully this side. And we'll move to the next presentation. A pleasure to introduce Dr. Junko Fujisaki, the next presenter. Dr. Fujisaki graduated from the GK University School of Medicine in 1983 and had training for internal medicine in University of Tokyo, pathology training in the GK University School of Medicine, and endoscopy training also in JK University School of Medicine. Now, Dr. Fujisaki is the Department Director of Gastroenterology in Medicine Department of GI Medicine, Endoscopy Department, of Cancer Institute Hospital of Japanese Foundation of Cancer Research. Dr. Fujisaki, please.
Thank you very much, Professor Choi. Kind introduction. 여러분, 안녕하세요. Chodi pada 감사합니다. Thank you. Thank you very much. Thank you so much for this opportunity to speak at the Second National Cancer Center Gastric Forum. I'd like to express my warmest gratitude to the chairman, Professor Yang Woo Kim, and the session chair, Professor Il-ju Choi, and Professor Chang Gyu Kim. Today, I'd like to talk about how to improve the curative resection rate of ESD for undifferentiated type early gastric cancer. Today's my presentation is about magnified endoscopic finding for undifferentiated type adenocarcinoma. So it may not be familiar to surgeon and oncologist. Anyway, let's start my presentation. No COI. This slide shows today's outline. First of all, this slide shows the result of JCOG 1009 and 1010. They are the result of a prospective study of undifferentiated type adenocarcinoma conducted in Japan. I'll give you an overview. The result of a 5-year prospective study of patients with undifferentiated type within 2 centimeter intramucosal region without ulcer scar, who underwent ESD. 275 cases were analyzed, and there were 195 cases of curative resection and 79 cases of non-curative resection. The 5-year survival rate for these cases was 99.3%. Based on these results, regions at these criteria became absolute indication for ESD in Japan. In fact, in this study, curative rate was 71% and the non-curative rate was 29%. The majority of the reason of non-curative factors were sites greater than 2 centimeters in 36 cases, 30%. Pathological T1B carcinoma in 33 cases, 12%. Ulcer and scar in 8%. Vascular invasion and lymphatic invasion were in 3% and 1%. Already reported non-curative rate of ESD for undifferentiated type adenocarcinoma was 16.7 to 36.1%. According to those data, majority factor of non-curative resection were depth and size. 3 reports describe size is the most non-curative factor, and 2 reports described about depth is the most non-curative factor. Let's move on to difficulties pre-diagnosis of undifferentiated type early gastric cancer. There are 3 points of pre-diagnostic difficulties for undifferentiated type: pathological T1B with or without ulcer scar, and its size. This region was a pathological T1B case. To see region on the anterior wall of the antrum, less than 2 centimeters in size, but ESD specimen revealed submucosal 15 micrometer invasion. This case could not diagnosis of pathological T1B endoscopically before ESD. Depth is the most difficult diagnostic point. This slide shows with or without ulcer scar cases. Upper slide shows 0 to 3 region located lower body of the posterior wall. There was no fold convergency, but pathological diagnosis was ulcer scar positive due to 3 slices fibrosis. Lower slide shows there appears to be a concentration of folds in the 2C posterior wall of the lower body. ESD specimen showed fibrosis, but only one section showed narrow fibrosis and was diagnosed as a biopsy scar. And the pathological diagnosis was without ulcer scar. Thus, the presence or absence of a scar can be difficult to determine endoscopically. This slide shows Japanese pathologist criteria using JCOC 1009, 1010 of ulcer scar. There was fracture of muscularis mucosa and fibrosis on over the 2 slices and thick fibrosis on 1 slice. It is difficult to distinguish between biopsy scar and ulcer fibrosis. However, diagnosis of ulcer scar is a key point of curative or non-curative. This slide shows accurate endoscopic diagnosis of ulcer scar from Japanese literature by stomach and intestine. 3 authors described that low sensitivity and low PPV. Next slide shows over the 2 centimeter region. 2C region is the mid-body lesser curvature. Lesion size expected 1 centimeter using white light image. And NBI without magnified endoscopy. ESD specimen was 2.7 centimeter. Pathological mapping revealed to be spreading around the depressed region. Histologically, proliferative zone infiltration was seen around the depressed region as blue line. I will also discuss the proliferative zone spreading, which affects the diagnosis of extent. In the case of undifferentiated type, as shown in the figure of depressed type early gastric cancer. Even if there is a cancer in the depressed area, the cancer may extend along the proliferative zone, covering the normal mucosa on the side, and the area may not be read endoscopically. In 2010, we published Digestive Disease and Science, measuring the number of extent of proliferative zone with normal mucosa covering the surface of the exposed area of cancer on the pathology specimen for the regions less than 2 centimeters in diameter. The results show that the size of the region is less than 2 centimeters. The proliferative zone is at the most 3 millimeters. The mean spreading the proliferative zone was about 600 micrometers. Based on the data, we considered it necessary to take a negative biopsy of the surrounding area, considering a proliferative zone of about within 5 millimeters as the largest, assuming a region size of 2 centimeters or smaller. Next, I will focus on the diagnosis of size. I will show the findings of magnified NBI for undifferentiated type adenocarcinoma. This case is 0 to 3 region located upper body lesser curvature. Biopsy diagnosed poorly differentiated tubular adenocarcinoma. Magnified NBI findings show the typical vascular pattern as undifferentiated type adenocarcinoma. So-called corkscrew pattern and wavy microvessel as the red line. Histologically, poorly differentiated adenocarcinoma located in whole mucosal layer. This magnified NBI finding showed wavy microvessel with large white zone as yellow circle. Histologically, poorly differentiated tubular adenocarcinoma were located mid to surface mucosa, but cancer were covered with surface normal epithelium as yellow marked. Next slide shows signet ring cell carcinoma. We can see vascular pattern and structure pattern. Demarcation line could be seen in red line. We could observe wavy microvessel on the red line with magnified NBI. Histologically, cancer occupied mid to surface mucosa. On blue line, magnified NBI revealed only extend the intervening part. Histologically, surface tufty mucosa remained. We could find white zone by magnified NBI. It was suggested surface epithelium remained. This slide shows small signet ring cell carcinoma located antrum. We can see pale region and magnified NBI findings shows only extended intervening part as large white zone can be seen. These signet ring cell carcinoma were located only proliferative zone histologically. We published on JGH 2011 summarized those data. We showed that the magnified NBI findings of undifferentiated type adenocarcinoma depending on its intramucosal cancer occupancy. In the left figure, when the cancer develops only in the middle layer of the mucosa, there is no vascular pattern and extended intervening part can be found. The mid figure showed the cancer has invaded mid to the superficial layer. Magnified NBI findings showed wavy microvessel and enlarged white zone. The right figure showed the cancer has developed in whole mucosal layer. We could observe irregular vascular pattern, the so-called corkscrew pattern. Enlarged intervening part findings revealed 58.3% of the region. Cancer occupied only proliferative zone. 72.7% of corkscrew pattern findings. Cancer occupied whole mucosal layer. We used these findings to determine the edge of the region by performing online marking with a magnified endoscope intraoperatively and confirming endoscopic online marking and histological accuracy. Here is the result. First, 53.9% were correctly diagnosed by white light image only. The positive diagnosis by magnified endoscopy was achieved in 12 cases, and the additional effect of magnified endoscopy was 27.6%, resulting in all-over positive diagnosis rate of 81.5%. Recently, we have been experienced and differentiated type adenocarcinoma arising from Helicobacter pylori and infected mucosa. As shown in the figure, characteristic finding of those regions were pale region and found in the funded gland area without atrophy. Most of them are characterized by pure signature cell carcinoma, growth only in the middle layer of the mucosa. Our report showed that the Helicobacter pylori and infected signature cell carcinoma had a lower Mibon labeling index than infected signature cell carcinoma, suggesting a lower cell proliferative activity. This is a case report of the case in which image could be observed 17 years ago annual endoscopy. And this signature cell carcinoma has the same morphology for 17 years, and at last, ESD was performed, showing that carcinoma remained within the mucosa. Those results of ESD cases of undifferentiated adenocarcinoma at our hospital, we compared with Helicobacter pylori and infected cases for EQRC2. Helicobacter pylori and infected cases, EQRC2 rate was only 2.7%, but infected cases was 22%. We also compare the result, the accurate diagnosis of extent of the region with magnified NBI. The present Helicobacter pylori infection, post-eradication, and uninfected cases. Accurate diagnosis rate was 60% for current infection, 93% for post-eradication, and 100% for uninfected cases within red square. In addition, about 36% of the cases with current infection showed wavy microvessel and corkscrew pattern, while most of the cases with uninfected showed only in extended intervening part showing red square. Finally, we present the result of a 4-point negative biopsy. Based on the previous result, we used a magnified endoscope to take a negative biopsy 5 millimeters from the demarcation line. This slide shows a suitable marking method, lateral margin negative in ESD for undifferentiated type adenocarcinoma. This is a 0 to 3 region, lower body of the great curvature. We performed margin of the region using magnified NBI and taking negative biopsy. 5 millimeters take a distance from demarcation line. And after confirmed pathological negative biopsy, we performed ESD marking according to negative biopsy. This case was done ESD as equal A with this slide. This slide shows the result case for negative biopsy. Curative resection rate was 80.3% as green circle. Lateral margin positive case were 3 cases, 2.4% in green circle. I'd like to show one of the lateral margin positive case. This case was a passing through case of 4 negative biopsy. Negative biopsy from 1 to 4 were performed using magnified endoscopy, but ESD resection margin was positive. Between 1 to 4, the cancer was extending in the direction of the oral side of the region. but it was extending between the negative biopsies. Rejected surgical specimen showed oral site 7 mm residual region. Summary. Difficulties diagnosis of the site due to undifferentiated type adenocarcinoma, proliferative zone spreading, covered with normal mucosa. Using magnified NBI is effective, the only white light image for the region spreading of undifferentiated type. Especially effective to diagnosis of extent of the region for Helicobacter pylori eradication and uninfected cases than infectious state. And additionally, 4-point cancer negative biopsy using magnified NBI is effective for before ESD diagnosis. Thank you for your attention.
Thank you very much for your very wonderful presentation. Now, this topic is for the question and comment.
Thank you for this, Haki. I'm Ryu from National Cancer Center Korea. In your presentation, the non-curative resection rate of undifferentiated is around 30 or 40%. Maybe that patient converted to the standard surgery, right? Gastrectomy.
Yes.
Yeah. The reason why we do the ESD instead of gastrectomy is to avoid gastrectomy. And if they do not got a standard surgery, some portion will develop recurrence and maybe death. So as a surgeon's viewpoint, I think that the gastrectomy conversion is a treatment failure of ESD. My viewpoint. So I think that when evaluating the efficacy of endoscopy, the endpoint, not only the recurrence, death, but also the gastrectomy conversion should be included. That's my point. So I wonder that how's the endoscopist opinion about that point?
I think basically, out of after pathological diagnosis, out of indication should be surgery. But I think for undifferentiated type adenocarcinoma, pathological T1B as we could not diagnose it before ESD because within not within 5 micrometer. For undifferentiated type, only 10 micrometer submucosal invasion, it is not non-curative. So, submucosal invasive diagnosis is it is impossible for us. And ulcer scar and ulcer scar is very difficult. But the only one we can diagnosis incorrect is the extent of the lesion within 2 centimeter. And over the 2 centimeter, it is very, I'm worried about over the 2 centimeter. For example, the size is 2.3 millimeter and 2.2 millimeter. But such a situation is in the future's study it needed. So for my opinion as endoscopist, how it is important to diagnose it as size is at least we can diagnose that correctly.
Any opinion from Korean side? Endoscopist?
Actually, I think even the non-curative resection rate is higher than differentiated type. And ESD is very safe and not minimally invasive. So a little bit much more higher non-curative resection does not help. It should not be treated as a standard. It's my opinion, but the problem, more than 50% might be a problem. So we have to much more study to accurately predict and decrease the surgical conversion rate.
Yeah, so I feel that it's a discrepancy between the endoscopist and surgeon.
Thank you for your nice presentation. I'm Juneng Lee, Samsung Medical Center gastroenterologist. So regarding the magnifying endoscopy, I understand that it's very good to make a resection margin negative, but it takes time, and we endoscopists in Korea usually don't want to do the magnifying endoscopy before ESD because we observe, make marking, and have to change endoscopy and do the resection. So for me, when the resection margin is unclear, I usually choose to cut a bigger section rather than do magnifying endoscopy. What's your opinion about that?
Before ESD, we study for the patient not ESD days. We performed the diagnostic endoscopy before ESD.
Another date.
Yes,
Yeah.
another day. And we diagnosed using a magnified endoscopy. It takes a long time, so I think 20 or 30 minutes under the sedation. And we decided the margin of the region, the 5 millimeter distance from demarcation line, take a 4 negative biopsy. But the size is 18 millimeter or about 20 millimeter. Such a large region is not 4 point, 5 point, 6 point negative biopsy. And after that, only ESD performing the day, we marking on the only negative biopsy, not using a magnified endoscopy.
Okay. So the magnifying endoscopy and 4-quadrant or 6-quadrant biopsy is good, but maybe you are doing magnifying endoscopy and 4-quadrant biopsy at your cancer institute hospital, but in another local Japanese hospital, how often doctors do the magnifying and endoscopy and 4-quadrant biopsy?
Magnified endoscopy is not so popular in all over Japan. But in our hospital, all the scope we perform the magnified endoscopy. I think almost all hospital using only white light image.
So that is the difficulty between the research and the real. So one more point. In Japanese JCOC study, the additional surgery rate among non-curative resection case was 92%. 73 patients out of 79 non-curative resection. So 92% additional surgery rate is very high. In the real clinical practice, the rate of additional surgery is usually around 60%. So it makes a problem in the real clinical practice. So what's your opinion about the difference between the additional surgery rate in the clinical trial and the real patient care?
Co-PI of the JCOG 1010 trial. I'm the PI of the 1010 trial. Actually, the inclusion criteria is very different from the clinical practice. Young patient and well-known informed consent, you get the informed consent, that patient is well-known. If my tumor removed by esophageal endoscopy is non-curative, I have to receive the surgery. They are aware about it. That's why the surgery rate is very high in the clinical trial. It's quite different between the clinical trial and clinical practice. And I think in Japan, the most of patients receive the surgery if the ESD was non-curative, except for the elderly patient. 80, 90% in Japan.
No patient usually
Gets a surgery, yeah. But they are very happy to receive surgery. Yeah, actually, the treatment, the ESD first is the standard treatment in Japan. As Professor Fujisaki mentioned, we cannot get to the precise pathological findings without ESD, especially for undifferentiated type of tumor. It is very difficult to determine the size, depth, and as she mentioned, the ulceration or not, and lymphovascular invasion or not. So the initial ESD should be performed in the patient with the indication of the criteria, I think. Not the failure of the ESD. Really? Complaint to endoscopist. No. In Japan, not so much patient claimed about yeah, that's right. But I think we can save the stomach about 60-70% of the patient if we perform the ESD at first. It's very important. The post-operative cure is quite different after ESD and after gastrectomy. We have to think about it.
As a Korean gastroenterologist, I don't think that additional surgery is a treatment failure. I think it's a step 2 treatment. If ESD is a standard initial treatment, if some bad factor is found, formal second line treatment is done. So it is a stepwise approach rather than a treatment failure.
I'd love to ask to you why does the non-curative resection in Korea the additional surgery rate is so low? You said it's a 60%.
Okay.
Why is it so low? I think it's so normal. In Japan, it's right. So 92%. So why is so low in Korea?
So
it's wrong, I think.
92% is non-realistic in the real clinical practice. It is only possible in clinical trial setting. So in the real patient, I understand that even in Japan, in retrospective study, the additional surgery rate is around 60 in big clinical trials.
So still I have a question. Still I'm very curious, because in Korean situation is a gastroenterologist need to explain seriously to the patients, the patient should get the surgery, right? So it's a wrong practice, I think, So you are doing very wrong, I think.
Okay.
What do you think about that?
So it depends on the hospital situation. In some hospital, we explain the patient before ESD that something not so good factor is found, you get surgery. Actually, in our hospital, the additional surgery rate is about 75 in non-curative resection case, much higher than the national standard. So we have to explain in more detail to the patient before ESD. So, okay, I will do better. Thank you very much for your important comment.
Yes, thank you very much for this question. So, and we are in the schedule. So, yes.
Yeah, now the chairman give a certificate of appreciation to Junko Fujisaki.
Thank you so much.
Now,
이준행쌤은 위암학회 회장님이세요.
we will take a 5-minute break, and then we start second section and 11:35. Good presentation of you. Ongoing image digital.
우리 저기 아니. 나도 좋아.
아, 선생님 뭐 와요.次のがちょっとなんか一回だけちらっと確認していいですか。あれこれでもこんなところで出るんですね。出ますね。OK、いいですね。そしてOK。出ますね。わかる。ポインター。OK。I can read this. Okay, it's okay.
아, 네, 갑자기 토론을 하셔가지고 네. 12시 20분. 네, 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 네. 11시 20분인데 네. So please take a seat, please. Now we will start the second session. The second session is the medical oncology and pathology session. The Professor Gun-won Yu will chair this session. Please start, Professor Yu.
Morning, everyone. It's my great pleasure to have a chance to chair this very difficult session for me. But as you know, we have a very world-famous doctor from Japan and 3 domestic doctors. The first speaker is Professor Narikazu Boku. He graduated University of Tokyo School of Medicine. And after the training at the National Cancer Center, he worked at the National Cancer Center and Shizuoka Cancer Center and returned to National Cancer Center. And currently, he is now professor at the Department of Oncology in University of Tokyo. His topic is present status of immunotherapy for advanced gastric cancer. Professor Boku, please.
Thank you for your kind introduction of me. And it is my great honor to be invited to this sophisticated forum. And my topic is present status of immunotherapy for advanced gastric cancer. This is my COI. Okay, let me start to compare among the 3 pivotal trials of the ICI for advanced gastric cancer. Okay, all of you know, recently we have 3 pivotal phase 3 trials of anti-PD-1 antibody. One is Checkmate 649, another one is a Keynote 859. This study was presented this year. And then attraction 4, this is an Asian trial conducted in Japan and Korea. So okay, so that we at first we would like to pay attention to the response and the response duration. As you know, all of the studies, the Checkmate 649, the difference of in response rate around 10%, 10%, and then 10%, very consistent results. And then response duration is longer than the control arm, the chemotherapy alone, in the Checkmate 649, in all of 3 trials. Then the duration of response is much longer in the attraction 4 trial, 13 months, so compared to the other trial, around 8 months. And then PFS, this ratio, the progression-free survival of the all randomized trials, regardless of CPS expression, combines positive scores. Then all 3 trials showed us significant prolongation of progression-free survival. Then the hazard ratio, they were very consistent in the 0.79 in the Checkmate trial and 0.976 in Keynote trial. In the attraction 4 trial, the hazard ratio was 0.76, much better than the other 2 trials. And however, in the 2 global trials, Checkmate and Keynote trials, show that it's significantly longer overall survival compared to the chemotherapy alone. However, attraction 4 trial failed to show the superiority of nivolumab compared to the chemotherapy alone. So even though the best hazard duration, the peak progression-free survival, and the best, longest chemotherapy duration. So we would like to consider about the reason for this failure. And this slide shows the right side, the left side, the x-axis show the proportion of the patient who received the subsequent chemotherapy after the first line chemotherapy. Then the y-axis median overall survival, and right side show the similarly the x-axis show the proportion of the patients who received the subsequent chemotherapy, and the y-axis show the post-progression survival. That is calculated by the overall median overall survival minus median progression-free survival. So that means the post-progression survival. Each dot show each dot show the clinical trials. The blue circle is a Western trial. Japan did not participate. And the red circle represents the Japanese trial conducted in Japan. And green circle shows global trial. Also, Japan participated. As you know that, as you can see here, the proportion of the patient who received the subsequent chemotherapy is much higher in Japanese trial, and compared to the other Western trials. Then, post-progression survival is very correlated with the proportion of the patient who received the subsequent chemotherapy very clearly. Then we put the checkmate trial and the keynote trial. N means nivolumab, P means the pembrolizumab, and C means the control arm. These four arms are located in the groups of the green groups of the global trial, and then right here and here post-progression survival also. And we put the attraction 4 trials. The attraction 4 trials, the median survival time was much longer than other clinical trial, but the nivolumab in the attraction 4 trial is located in the almost about in the among the red groups and Japanese groups. However, in the control arm of the attraction 4 trial, showed a much longer post-progression survival than other trials. So that's a big. So I don't think why that this is much longer than the other trials. Maybe by the subsequent of use or something, or I don't know. But so subsequent chemotherapy have some big impact on the survival benefit of the evaluating the survival benefit of the ICIs. And another topic is here. I show the overall survival curve of attraction 4 trial. You can see here the difference is getting larger over time, especially 3 years after 3 years. And then I'd like to know the hazard ratio in each year. So let me start the calculation. So you can see here that from after 1 year, from 67% to 37%. So multiply by 0.56. As you can understand, I think. And then we obtained these 6 numbers. I put these numbers to the model of the exponential model, survival model. Alpha means alpha represents the hazard. Then we can approximate the alpha 1 hazard in each year. Then like this, 0.679 alpha is 0.39 something, and then 0.64, 0.45. And then we can get a hazard ratio in each year. As you can see here, like this. Okay. And then we compare the hazard ratio in each year, first and second and third year, between the stick-mate trial and attraction for trials. As you can see here, overall, the first year, second year, third year. As you can see here, the hazard ratio in the third year is very similar between the two trials. I think because the impact of influence of the second or third line chemotherapy in the control might be diminished in the third year. So that means a long-term efficacy of nivolumab. Okay. And then let me move to the other topic of the impact of the CPS combined positive score, the expression of the PD-L1. Now you can see here the hazard ratio is getting better along with the cutoff level of the CPS, 1%, 5%, 10%, hazard ratio is getting better. But however, regardless the CPS level, the expression level, the difference of the response rate is not so different. Some kind of almost around 10% in each group. And let me start to the let me start from the hazard ratio. As I showed in the previous slide, I calculate the hazard ratio in each year of the subgroups with CPS 5 or more, 5 or higher. You can see here the hazard ratio is getting better over time. So the best hazard ratio is obtained in the third year. So that means that long-term efficacy is very prominent in the patient with CPS 5 or higher. And then all population CPS 5 or higher, that is in the previous slide, and then CPS less than 5. As you can see here, as I said, the hazard ratio is getting better, over time in that patient with CPS 5 or higher. However, the hazard ratio is getting worse over time in the patient with CPS less than 5. So that means long-term efficacy of nivolumab is prominent in the CPS 5 or higher, but not in the less than 5 populations. Then I'd like to consider about the response rate. As you can see here, the difference in the response rate is not so large among regardless hazard ratio. However, we have to pay attention to that complete response rate. Here, in the attraction for trial, the complete response rate is numerically higher in the CPS 5 or higher subgroups compared to the CPS less than 5. And then this slide shows the landmark analysis of according to the response. The deepness of response, 80% of higher, the very large tumor reduction. Here, almost 7% of difference there. Then, as you can see here, the deep purple is frequently seen in the deeper response groups. Then, in the CPS of 5 or higher patient populations, the deeper responder showed a very, very long overall survival, 44.8 months. It's almost longer than 3 years, almost 4 years. But even in the subpopulation of the CPS 5 or higher, however, in the CPS 5 less than CPS less than 5 populations, the median overall survival time 25.6 months. That's not bad, but compared to the CPS higher group, the long-term efficacy is not prominent in the CPS the population of CPS less than 5. On the contrary, the patient with the best response of PD the population in the control arm, chemotherapy alone arm, the CPS of 5 or higher population, progression-free median overall survival 7.7 months. That's poor, but CPS less than 5, 10 months, but not big so difference. However, in the nivolumab arm, with the patient of the best response PD, the CPS 5 or higher subgroups, median survival time 8.6 months like this, and then CPS less than 5, median survival time only 5.1 months, very poor. As you can see here, the overall survival curve drop rapidly here. Then, so disease progression in this population with CPS less than 5 might be associated with something bad, like a hyperprogression, I guess. And then let's move to the new drugs. So as you know, so the bevacizumab anti-claudin antibody, they show the positive result in the overall survival in the spotlight trial, global trial, and another one is the growth trial, Asian trial. And then so they show the very clear difference in overall survival. And then in these two spotlight and growth trial, so Japanese patients show the best hazard ratio. That's very curious, interesting. So in other clinical trials, hazard ratio of Japanese population, the patient is worst in other all trials. But this trial, Japanese population patient show the best hazard ratios consistently. I don't know why reason for this response, the good hazard ratio in Japanese population, good management of the side effects or enhancement efficacy of by the following nivolumab in Japanese population, I guess. I don't know. And then, so claudin positive population is about 30% of the patients, and then even if the claudin positive population, half and half patients show the CPS 5 and less, 5 or higher or less than 5. So we are now discussing about the double positive population, CPS 5 or higher, or claudin, and then claudin positive, maybe 15% of the instance of the 15%. So we should, how we differentiate, how to use that, how to select that out of these two agents for these double positive populations. Then in the keynote trial, the CPS of 10 or higher population showed a very good progression-free survival, 25% at 2 years, and then the overall survival time almost 40% at 2 years. So we compared these trials then according to the CPS populations, and then check spotlight trial showed a very good high 2-year survival rates, 39%. Compared to this, 856 and checkmate 649 trials, then CPS or higher 10 or higher population showed a very similar overall survival rate, 2-year survival rates. So personally, if the patient showed a CPS of 10 or higher, I would like to select the nivolumab or pembrolizumab because those bevacizumab is so toxic. So that's my personal opinion. And then next topic is Next topic is the impact of MSI high. In the checkmate trial, the MSI high population showed a very good survival results. And then, so Then in Japan, we conduct the no limit trials. So we screen the gastric cancer patients for MSI status all over the Japanese, and we collected more than 10,000, almost 10,000 patient result, and then enroll the patient and with CPS high populations, level 1 plus ipilimumab, no cytotoxic agents, only ICIs. The response rate is 62.1% is very good results, and the progression-free survival almost 1 year, and overall survival not 1 year survival rate 80%. So this is a good result. So in the future, if for the cytotoxic agent is not necessary for the maybe it's not necessary for the MSI high populations. And then last topic is ICI for HER2 advanced gastric cancer patient. As you know, Keynote 811 study trial is showed up addition of pembrolizumab to the trastuzumab and the cytotoxic agent to HER2 gastric patients. The hazard ratio, the response rate significantly higher, and then progression-free survival was significantly longer. However, in the third interim analysis, the overall population, the primary endpoint was not met in terms of overall survival. The hazard ratio was 0.84. And then let me look back to the history of the development of the anti-HER2 therapy, trastuzumab. This study showed a hazard ratio 0.84, very similar. I don't know. The Japanese government approved pembrolizumab for the HER2 advanced gastric cancer patient. I don't know, but I hope, because European country approved this agent for the pembrolizumab for the HER2 advanced gastric patients. So I don't know Japan, but I hope. Okay, that's my talk. Thank you for your kind attention.
Thank you, Professor Boko. Is there any question?
Yeah, congratulations on your success in the no limit trial. Nivo-EP is especially efficacious for MSI high tumors. And could you suggest a mechanistic molecular mechanism why CTLA-4 blockade is especially efficacious for tumors with MSI?
Sorry, I'm not a basic researcher, but I conducted the translation research around the nimotherapy, nivolumab alone patient among the patients. In that study, the CTLA-4 expression in the peripheral blood and in the tumor tissues, they had a worse impact on the overall efficacy of the nivolumab alone. So that means that CTLA-4 subgroup, the immune cells have some negative impact on the immunotherapy of advanced gastric cancer.
Okay, thank you very much, Professor Boku. I'm very interested in the immunotherapy, and then actually I was also kind of a co-investigator for the Attraction 5 adjuvant trial. So I'm very happy to see the very good results from 3 kind of first line kind of trial for the immunotherapy for the gastric cancer is all positive. But I'm curious why there is a kind of hyperprogression or it happened, and then the proportion of the hyperprogression, it doesn't matter in the clinical practice, or is it really hyperprogression, a true progression, or kind of a possibility of a pseudo progression?
Okay. Yeah. Okay. So, but at first, the incidence of pseudo progression is very rare, very rare. In the Attraction 2 trial, only 2 patients showed the pseudo progression, and then I don't know the exact, the precise mechanism of the hyperproduction, but from the Osaka University, I compare the tumor growth rate immediately previous chemotherapy and then after and then nivolumab alone. But that means the second line and third line in Japan in National Cancer Center. The 2 times larger, the faster progression was observed in 30% of the patient compared to the previous study in the nivolumab arm. And then in the past, the third line irinotecan, 15 patients showed that 2 times, 15% of the patients showed that 2 times faster progression. So hyperprogression can be seen. It can be seen in even in the cytotoxic agents, but the incidence is much higher in the ICI. But and then my speculation. So gastric cancer is occurred in the inflammation field. Some immunologic action or some kind of cytokine, of, I don't know, but some kind of cytokine something may promote that tumor progression because as I said, gastric cancer is originated from the inflammatory background. Okay. And immunotherapy may enhance the progression in some patients. So I don't know why, but this should be. And then Osaka University patient, the group's colleagues reported that the incidence of hyperpollution is higher in the low CPS patients. Yes. Okay. Thank you.
Thank you for the great talk. As you showed in Attraction 4, the overall survival of 2 groups did not differ, but the progression-free survival was superior in the nivolumab group. So my assumption was that subsequent immunotherapy in the control group might have diminished the difference of PFS superiority in the overall survival. So how many proportion of patients in the control group actually received the subsequent nivolumab, and do you think that could have actually affected the survival?
Okay, and then in the overall population, in the Attraction 4 trial, that means Japan, Korea, and Taiwan, over 40% of the patients received the subsequent nivolumab. But in Japan, around I remember 60 or 70% patients received the nivolumab. And then my personal information from the checkmate groups, also in the Japanese population, checkmate 649, the hazard ratio, in the Japanese subgroup is higher than 1.0. So very consistent. The proportion of the Japanese population is smaller in checkmate trial, larger in Attraction 4 trial. So I don't know which is better, first line or subsequent salvage line use of nivolumab, but actually maybe 50% of the patient in clinical practice, maybe half of the patient can receive the third rank chemotherapy. So I prefer to use the nivolumab in the first line because half of the patient cannot receive the nivolumab. Okay.
Okay. Thank you, Professor Boku. We will move to the next speaker. Next speaker is Professor Hak-Kyun Kim. He graduated Seoul National University in 1997, and after the training at the SNU Hospital, he joined the National Cancer Center, Korea, more than 40 years ago. He is now currently a deputy director of Onco Innovation Unit. So his topic is chromosomal instability as a prognostic and predictive marker. Professor Park, Kim, please.
Thank you for your introduction. Chromosomal instability, as you all know, is a poor prognostic factors in many tumors. SIN represents about 70% of gastric cancer. And it's a hallmark of cancer and attributed to the several distinct processes, including telomere dysfunction, mitotic errors, and homologous recombination defect. And several distinct phenotypes resulting from these processes include HRD and chromothripsis. We and other groups already reported that SIN group is a poor prognosis population in diffuse type, and it is independent prognostic factors, independent of the recurrent fusions and incadin mutation. Now, since SIN represents 70% of gastric cancer, SIN positive and SIN negative gastric cancer mean nothing to clinicians. We need to break down the specific types of SIN and evaluate the prognostic and predictive impact of each subtype of chromosomal instability. So we did a whole genome sequencing analysis to more evaluate the chromosomal instability in more detail. One of the areas we focused on was the chromothripsis. Chromothripsis is a catastrophic event leading to chromosomal instability. It is a massive genomic rearrangement localized to isolated chromosomal regions, and results from the telomere dysfunction. And it is a poor prognostic in many types of cancer, including myeloma, medulloblastoma, triple-negative breast cancer, and colorectal cancer. But its prognostic impact in gastric cancer is not yet known. Whole genome pan-cancer analysis of whole genome consortium study, which did the whole genome sequencing of several different tumor of the tissue type, evaluated chromothripsis in gastric cancer, but it's relatively small in number. And more importantly, the gastric cancer included in this study had a very short follow-up duration, median of 6 months. So prognostic impact of the chromosomal instability cannot be evaluated in this study. Another study published by the Chinese investigators evaluated also chromothripsis, and they reported the frequency of chromothripsis 4.8%. But also in this study, the prognostic impact was not evaluated. So Seoul National University and National Cancer Center, directed by Dr. Young Kim, gathered 100 fresh frozen gastric cancer tissue samples, and these samples were subject to whole genome and whole transcriptomic analysis. The strong point of this sample set was that since our National Cancer Center has a tumor bank since it opened in 2001, so these samples had a median follow-up duration of 103 months. We characterized the various types of genomic instability and evaluated the clinical pathological correlates and prognostic relevance. The median sequencing depth is approximately 50x, and recurrent somatic mutations were similar to those reported by the whole exome sequencing, with p53 mutation being most frequent. And we did, since this is whole genome sequencing study, we were interested in whether we were identified recurrent non-coding mutations. So mu6EB was conducted using non-coding mutations only. But when we did that, we could not find recurrent non-coding mutations. Consistent with the prior reports that the recurrent non-coding driver mutations are very rare compared with coding driver mutations. And when we did the copy number analysis, also similar data came out as
those reported by the whole exome sequencing, with the ORB2 mutation, ORB2 gene amplification being most frequent. For detection of chromothripsis, we use the Shatter-seq with the high confidence calling being defined by at least 7 contiguous segments oscillating between 2 copy number states. And we visually inspected the result. And as a result, we identified 22 gastric cancer that harbored at least 1 chromothripsis events. So in our data, the chromothripsis rate was 22%. And we evaluated chromothripsis association with the copy number alterations. The significantly amplified regions were preferentially localized to chromothripsis regions. So there were significant overlap between chromothripsis and focal gene amplifications. More specifically, for amplification in the MYC and cyclin E1 were significantly enriched with the chromothripsis regions, and CDKN2A deletion was localized to the chromothripsis regions, as we reported in the other tumor type. This is an example of the focal gene amplification that overlapped with the region of chromothripsis. The SV, these arcs represent SV, and these are breakpoints. And as you see, the cyclin E1 gene amplification overlapped in the region of the chromothripsis in patients with intestinal type gastric cancer. Age, gender, histologic subtype, and primary tumor location were not different between GC with chromothripsis and those without. And chromothripsis is more frequent in polypoid tumors than in diploid tumors. And chromothripsis rate was higher in 50 mutant tumors than wild type, but the difference was not significant. And the number of chromothripsis events was associated with poor prognosis with hazard ratio of the 1.3. And consistent with this finding, 22 gastric cancer with GC that harbored at least 1 chromothripsis events had worse prognosis than those without chromothripsis. And median survival time was 55 months versus not reached. And here's the number of the chromothripsis events per chromosome, and chromothripsis events did not show clear predilection for the involved chromosomes. And 21 of the 38 chromothripsis events involved multiple chromosomes. And this multi-chromosomal chromothripsis was associated with the higher hazard ratio for death of the hazard ratio of 1.99. And patients with multi-chromosomal chromothripsis events had poorer overall survival than those without multi-chromosomal chromothripsis, median survival of 38 months versus non-reached. So actually, we were not surprised by the poor prognosis associated with the chromothripsis itself, but we were surprised by the very poor prognostic association of the multi-chromosomal chromothripsis. Since we also did the RNA sequencing analysis, we tried to identify in-frame gene fusions among these 100 gastric cancer. And none of these 25 in-frame gene fusions were recurrent, so present in only one tumor. And also this recurrent gene fusion we identified in this 100 tumors did not overlap with the 25 gene fusions we previously identified in 80 diffuse gastric tumors. So our impression is that the gene fusion in gastric cancer are rarely drivers and rarely recurrent. Anyway, this gene fusion did not overlap with the multi-chromosomal chromothripsis we identified by the whole genome sequencing analysis. The other type of the chromosomal instability is the homologous recombination deficiency. We used the CORD algorithm, which is a classifier of homologous recombination deficiency, based on the whole genome sequencing data. And using PORT, the homologous recombination deficiency rate was 5% of our data set, and they did not overlap with chromothripsis, and there were no significant correlation between these two processes, and homologous recombination defect was not associated with the poor prognosis. Previously, we reported that the germline mutation rate in gastric cancer, in early onset gastric cancer was about 8%. And among these 8, we identified several pathologic germline mutations in homologous recombination pathway, such as RAD51D, pelvic2. But in our data set of 100 gastric cancer, no homologous recombination pathway mutations were identified. So we identified only one mut YH germline mutation only. So most of these homologous recombination defect tumors result from the somatic mutations in the homologous recombination defect. Anyway, we were interested whether we could identify some therapeutic targets among these homologous recombination deficient tumors. So we compared the gene expression profile between these 5 HRD tumors versus 95 HRP proficient tumors. Interestingly, we identified several immune-related genes were upregulated in the HRD tumors. And among the pathway, hematopoietic cell lineage was most significantly associated with the gene overexpressed in HRD tumors. Prior study reported that 12 chemokines reflect intratumoral immune reaction in melanoma and lung cancer. So we evaluated these 12 chemokines in our groups, and 3 out of 5 HRD tumors of our data set were categorized as the overexpressor of these 12 chemokines, while the other HRP tumors were mostly classified as the non-expressors of these 12 chemokines with a significant Fisher exact test result. And the expression, some of the expression of these 12 chemokines was significantly higher in our 5 HRD tumors compared with the 95 HRP tumors. I think this is important because when you downloaded the RNA expression sequencing data from another study of the patients who were treated with pembrolizumab alone, and in this study, some of the expression of these 12 chemokines was significantly higher in the clinical responders to pembrolizumab. So the fact that our HRD tumors had higher expression of higher expression of these 12 chemokines suggests that these HRD tumors are more responsive to immunotherapy hypothesis worthy to be tested in the clinical trial in the future. So making the most of the frozen tumors with long duration, we were identified for the first time to our knowledge that the chromothripsis is a poor prognostic genomic alteration in a subset, approximately 22% of the whole gastric cancer in Korea. And I think that since the whole genome sequence data will be more readily available for post-operative prognostication, such as in UK, if validating larger cohorts, this whole genome sequence data may be translated into diagnostic aid to clinicians after surgery in the future. And HRD gastric cancer overexpress chemokines, suggesting a pretty potential for HRD for immunotherapy. And thank you for your attention.
Thank you, Professor Park. Is there any comment or question? Yes, please.
Thank you. Thank you for your good presentation of your excellent work. I have a basic question. You mentioned about the chromosynthesis. How do you determine this patient is a positive and that patient negative?
Yeah, the chromosynthesis is can be. We need to be very careful differentiating between chromosynthesis and multi-step chromosomal rearrangement, because chromosynthesis is a single event. And most people think that this happens early in the development of the tumor. And multi-step chromosomal rearrangement happens throughout the carcinogenesis processes. So the hallmark of the chromosynthesis is this more than 7 contiguous genomic segment oscillating between 2 copy number states, because this is a single chromosomal event and they are tethered again. So this oscillating pattern is very characteristic pathognomonic of the chromosynthesis events. And Shatter-seq package of the whole genome sequencing data was used by the whole genome pan-cancer whole genome analysis group, and this is a validated algorithm they used. So we downloaded this software package, and we did the same process. We used the high confidence holding of this package, and then visually inspected to filter out the multi-step chromosome rearrangement to exclude possibility of the multi-step chromosomal rearrangement may be mistaken as a single event chromosynthesis.
Thank you.
Any other question or comment? Yes, please.
I think people could have some curiosity about the meaning of HRD in gastric cancer. Is it related to some kind of a genomic kind of changes, like a BRCA mutation in the breast cancer or other cancers?
So the people are interested in the HRD because they are pretty marker for the PARP inhibitor. So for PARP inhibitor to be effective, the BRCA NIS should be present in the tumor. So if we strictly define HRD as a BRCA NIS, then this core classifier of homologous recombination deficiency is currently regarded as the standard analysis algorithm for the genomic data, because they were trained by the known BRCA1/2 mutant breast and ovarian tumors. BRCA1/2 mutation lead to single base level mutations in DELs, as well as chromosomal rearrangement, LOH, and telomere rearrangement. And all these are represented in the whole genome sequencing data. And this cohort consider all those genomic rearrangement to train BRCA1/2 tumors and use that algorithm to predict whether such BRCA is present in the independent set of samples. And so since this is most comprehensive analysis available in the scientific community currently, I think that this 5% estimate of the HRD may be the best estimate of the BRCA rate of the gastric cancer, because the rate varies a lot depending on the method we use. For example, the myriad HRD SCAR score, otherwise known as GIS. If we apply SCAR score, the TCGA gastric cancer has approximately 25 to 30% positivity of the SCAR HRD high, which is higher than 42. But I don't think 25 to 30% is actual true positive rate of the PRC in gastric cancer. And I would say that 5% is better estimate, but we need clinical trials for the PARP inhibitor to know exactly how many gastric tumors are really benefit from the PARP inhibitors.
Okay, thank you, Professor Park. Ruskin. Let's move to the next topic. Now, next speaker is Professor Bokun Jang. He graduated Seoul National University and majored in pathology training at the Seoul National University. And currently, he is the assistant professor at the Jeju National University. His topic is the targeting precancerous region. Professor Jang, please.
Oh, thank you for your kind introduction. I really appreciate for inviting me. And Dr. Boku talked about the immunotherapy and chemotherapy in advanced gastric cancer. And today I'm going to talk about the the other spectrum, which is a drug named Pervinium palmoate, which I think is the potential candidate targeting gastric precancerous lesions. So we are all aware that it would be much better if we could prevent gastric cancer development in the first place. So last year, I was given a chance to go to the United States, Vanderbilt Medical Center, which is located in Nashville, Tennessee. And thanks to Dr. Gordon Ring and Dr. Choi, I was able to study gastric precancerous lesions with mouse models and the gastric organoids. So Dr. Gordon Ring and Dr. Choi primarily working on the gastric precancerous stage in the gastric carcinogenesis, such as metaplasia and dysplasia. So actually, the Gordon Ring is the scientist who coined the term SPAM first in the world. So I don't think you're familiar with SPAM, but it's a kind of gastric metaplasia. So they generated a couple of mouse models. For example, they induced mutant KRAS in the progenitor cells or in gastric chip cells. And interestingly, they found that when mutant KRAS is expressed in gastric chip cells, which can lead to metaplasia and dysplasia in order. So using this mouse model, they decided to develop the gastric organoids with metaplastic and dysplastic features respectively. So when KRAS is induced in 3 months, the gastric mucosa is completely replaced with the metaplastic glands. And in 4 months, the dysplastic glands start to appear and become predominant. So the gastric mucosa are harvested at 3 months and 4 months respectively, and they successfully established gastric organoids of metaplasia and dysplasia features. So that they named them Meta3 for metaplastic organoid and Meta4 for dysplastic organoid. Then they demonstrated further by implanting dysplastic organoid implanting the mice. They proved that it can progress into invasive cancers and revealed some genetic alterations involved. And in addition, they found Pervinium can specifically kill dysplastic organoids. That's when I joined the team, and I was lucky because they allowed me to take on the project investigating the molecular mechanisms by which Pervinium suppresses metaplasia and dysplasia progression. So I'm a little concerned because I'm going to talk about signaling pathways. So it could be very boring. So I do my best to make it very quick. So this is a Pervinium palmoate, which is actually an antiparasite. And it is still available in the market only in Japan and Germany. So I'm really wondering if this information is true, and has any one of you ever taken it as a kid. So, you know, in this graph, the graph shows that its use as antiparasite peaked in 1960s, 70s, and it declined since because, you know, other with the development of other drugs. But surprisingly, since 2000, its cancer effect has been reported in some papers, and a lot of, you know, researchers are interested in the repurposing Pervinium as an anti-cancer drug. So regarding its anti-cancer effect, the Wnt and mitochondrial dysfunction has been the mode of action of Pervinium. So at first and so I want you to notice the difference in morphology between meta3 and meta4. So as you can see here, the meta4 has thicker epithelium and has very irregular and, you know, distorted architecture, which clearly showing the dysplastic features. Oh, I'm sorry. The meta4 dysplastic organoid express the dysplastic marker TROP2, which is in green color. So when we treated cells with Pervinium, the metaplastic cells, they don't die, they survive, but they don't grow very well compared to control. But dysplastic organoids, they all die by Pervinium treatment. And you can see here PRA, which is a trametinib, which is the MEK inhibitor, blocking the MEK kinase pathway. So we found that MEK kinase pathway inhibition alone is not enough to induce cell death in metaplastic and dysplastic cells, but Pervinium only induces cell death in dysplastic cells. That's what we first discovered. And, you know, as I mentioned earlier, the Wnt pathway in mitochondria was the known target of Pervinium. So we hypothesized that maybe CK1 alpha and Wnt pathway would be the target of Pervinium. So we tried SSETC3, which is newly developed, very specific CK1 alpha and Wnt pathway molecule. But however, surprisingly, it has no effect at all. So we thought that, okay, Wnt pathway is not responsible. Then what pathway? That's when we decided to perform the phospho antibody array. And we found that STAT pathway is the most affected pathway by Pervinium treatment. It was very significantly downregulated. More specifically, we found that the phospho-STAT3 is very significantly downregulated by Pervinium treatment, as well as, the PERK. Phospho-STAT3, you can see the decrease of phospho-STAT3 by Pervinium treatment, as well as phospho-ERK. There was one thing that puzzled us at this point, because, you know, the phospho-STAT3 expression was also downregulated in META3, but we already know that, you know, the META3 doesn't die in response to Pervinium. So we came up with this idea that the cancer addiction to certain signaling pathway. So we already know that oftentimes cancer cells are addicted to certain signaling pathway, so they become too dependent on the pathway, then they become sensitive or undergo apoptosis when it's blocked. So when you look at the basal levels of META3 and META4, I mean the phospho-STAT3, the phospho-STAT3 basal level is much higher in META4. So we imagine that the dysplastic cells are only addicted to STAT3 pathway. That's why, you know, META4 is very sensitive to Pervinium treatment. STAT3 is a very well-known transcription factor involved in, you know, the development and progression of multiple types of cancers. And there are many small inhibitors in the market, So we tried 3 different STAT3 inhibitors: static, STAT3-IN1, CPT, and metaplastic cell. When treated metaplastic cells with these inhibitors, no effect at all, again. However, metaplastic organoids, the meta4, you can see here, oh, sorry. They seem to respond a little, but not as much as Pervinium. So we thought that, Pervinium blocks the phospho-STAT3 as well as phospho-ERK. So we figured that blocking both pathways might be necessary to induce a cell death. So we tried. This is STAT3 inhibitor alone, and then we treated both MEG inhibitor and STAT3 inhibitor. Then the meta4 cells die as much as Pervinium treatment. So we learned that blocking both pathways is necessary to induce cell death of dysplastic cells. So we wanted to identify the cell types affected by Pervinium treatment. So we did single-cell RNA sequencing. Green is control, and the purple is the Pervinium treatment group. Not surprisingly, there's a clear separation between them. And the dysplastic stem cells, we define them as CD133, CD166 double positive cells. They mostly confined to the control, but the Pervinium treatment group is mostly composed of damaged cell clusters. And we found that the dysplastic cell population is significantly decreased in response to Pervinium. Okay, then we move on to the in vivo study. So we tried to examine the in vivo effect of Pervinium. So do you remember the KRAS mice, 3 months, 4 months? So we tried the Pervinium for 1 or 2 weeks. So here, this is the wild type mice, the packed with parietal cells, which is in green. And then the KRAS mice, in 3 months, they replaced with the metaplastic or dysplastic glands completely. There is no parietal cells. Pervinium treatment for 1 week or 2 weeks somehow restored normal parietal cells here. If you look at a little bit more close, then these UEA1 positive cells represent the mucous cells of metaplastic and dysplastic glands. And the Ki67 positive proliferant cells also decreased in response to Pervinium treatment. And under microscope, definitely we can see that the degree of dysplasia and proportion of dysplastic glands also decreased. So these findings, that clearly demonstrate that Pervinium treatment can suppress dysplastic progression in KRAS mice. This is the immunohistochemistry to prove the phospho-STAT3 downregulation by Pervinium treatment. And we also observed a global decrease in the immune cell infiltration. Next is we being very happy and excited about this, the wonderful outcomes with mouse models. So we wanted to validate the result with human gastric organoids as well. So we try to generate human organoids from the gastric cancer specimens. So the non-cancerous gastric mucosa was obtained from adjacent to gastric cancer was obtained. And eventually we established the 20 human gastric organoids, and we measured morphology and dysplastic and metaplastic marker expression. And we also treated cells with trimethylene, Pervinium, and combination of them, and measured the response to those drugs. Interestingly, we found that some human gastric organoids were very sensitive to Pervinium, like a dysplastic organoid in the mice. Here you can see the pycnotic cells, they die after Pervinium treatment. And some of them are very resistant to Pervinium. There was no effect at all. They don't die, just a little bit, delayed in the growth. So we try to identify which characteristics are associated with the Pervinium responsiveness. We already know that the phospho-STAT3 is very involved in the in the response to preventive treatment in the mice. So we, we figured that those dysplastic features are also involved in human gastric organoid lines as well. So we measured morphology and dysplastic marker expression, TROP2, and here you can see the positive correlation between pervinium responsiveness and dysplastic morphology and dysplastic marker expression. And as I said, I talked about the addiction to phospho-STAT3. So we compared the basal levels of phospho-STAT3 expression. So pervinium sensitive, indeed, pervinium sensitive organoid lines have much higher basal phospho-3 levels than pervinium resistant one. And we also tried, the STAT3 inhibitors, STAT3, IM1, static, and CPT, just like we did in the mice. So as you see here, pervinium resistant organoid lines grow very, very well, whereas the pervinium sensitive lines seems to die a little, but not as much as pervinium. So here you can be confirmed with Western blot that pervinium sensitive organoid lines very responsive to pervinium, and the phospho-STAT3 levels significantly decreased, and phospho-ORCA as well. But not in the pervinium resistant organoid lines. Okay, so let me summarize the key findings. So we discovered that pervinium palmoid can suppress both the signaling pathways, phospho-STAT3 and MEK kinase pathway. In metaplastic cells with low STAT3 activity respond to pervinium. They don't die, but they just don't grow very well. It's like a growth arrest. Whereas dysplastic cells, they quickly respond and they almost die. It's because we thought it's because of higher STAT3 activity, which we think is probably can be called, the dysplastic cells addition to STAT3 activity. Thank you for your attention. These are team members.
Thank you, Professor Zhang. Any question or comment? Yes, please.
I'm also interested in the phosphoproteomics analysis. We developed the analytic system using endoscopic biopsy, and we can measure the more than 20,000 phosphorylated sites. But we propose that such an organoid analysis using the organoid. But my colleague, basic researchers, the culture medium of the organ culture contains many growth factors. So these factors have some impact on the cancer cells. So your research is using the organoid, and then you analyze the signal transduction pathway, and then so how do you differentiate that? How do you neglect the influence of the growth factors?
That's a really good question, and that's the one of the very important limitations of this organoid experiment. We cannot exclude the impact of the organoid culture media. There are, as you said, there are so many growth factors. That's why we can grow the normal cells, not cancer cells. So in fact, there is no way. We have to consider that factor, and that's why we have to compare between normal organoid and some metaplastic or dysplastic or cancer organoid.
And then the difference between the metaplastic and dysplastic is very interesting. So, but you can show that you show the apoptosis in the dysplastic lesions, cells. Then, but why do you pay attention to pervinin? So you have other candidate agents, but why do you select this agent?
Well, it was done before I joined the team. So I have, I don't have an idea of the detailed history, but I heard that they found the palmoids by not throughout, not the high throughput screening, but they did some screening. Like, I mean, some molecular inhibitors or something. Then they found the pervinium is very effective in killing these spotted cells.
Thank you. Thank you very much. So you are a pathologist that, and you know already that, dysplasia in the stomach, the phenotype is a adenomatous polyp, or right? So metaplasia we could see also, but of course, metaplasia cannot be, treated by endoscopically, but some adenomatous polyp, am showing the histopathologically dysplasia, high grade or low grade, can be removed by just like a polypectomy very easily. So why we need to use this kind of medicine, I don't know. But anyway, there are pervinium. So what do you think is the proportion of the patient, who get the benefit from this kind of STAT3 signaling pathway blockade by pervinium?
Well, that was a really critical point. Then I have actually no answers. I think as a surgeon, you have a very clear point. What's the use of this medicine when you can just remove the adenomatous polyps by endoscopic intervention? The thing is, we believe that not many gastric cancers develop directly from the adenomatous polyps, and there are so many gastric. I think from my experience and many experts say that there are many gastric cancers develop kind of from non-visible dysplastic stage, right? So in fact, as a pathologist, I see a lot of the gastric biopsy specimens, metaplastic specimens. Then I feel that, oh, it looks really dysplastic, but it's not adenomatous polyp. But there is no way to just say it's metaplasia. But I have a feeling that it's too dysplastic. It's too strange. I believe that's the target that's the reasons that we can target with this the medicine. And in fact, the pervinium palmoid, there's big the advantage of this drug. It's being used as anti-parasite drug, which means that it's very safe. You can take it orally, and so if clinical trial is going well, and if it can prove that it can be helpful to prevent gastric cancer from, I think it would be better if we try with gastric cancer patients first, and then to see whether it can prevent metachronous cancer, because their cancer, the field effect, they have very high chance for the metachronous cancer or recurrence. So that's the way we could try first.
Okay, maybe everybody knows that recently the Korean cancer terminal patient looking for the anti-parasite drug for the cure, some last hope to cure their cancer. So it's very cautious to interpret some certain laboratory data and the real clinical situation. Thank you, Professor Zhang.
Thank you.
Let's move with the last speaker of this session, Professor Myung-Chul Guk. He graduated Seoul National University in 1992, and after training with the SNU Hospital, he joined the National Cancer Center more than 20 years ago. His topic is a characteristic pattern of background in the mucosa of MSI type gastric cancer. Professor Guk, please.
Thank you, Chairman. My presentation is very short, so I think we can keep the lunch time. In chronic gastritis, the inflammation makes the epithelial damage, and if the damage is ongoing, the gland is lost and it becomes atrophy. When the regeneration occurs, it can be fully recovered to native gland, but sometimes it is replaced by another type of gland. So it is replaced by non-native gland. We cause in metaplasia. So the atrophy include non-metaplastic atrophy and metaplastic atrophy. Intestinal metaplasia is the major type of metaplastic atrophy in gastritis, and it can be divided into incomplete type and complete type. Incomplete type means a mixture of intestinal epithelium and gastric epithelium. Lorentz classification is Lorentz classification is makes include intestinal type and tissue type, and the intestinal type is known to be occurred in the background of intestinal metaplasia. So we think that this Lorentz classification can reflect gastric carcinogenesis. So the normal mucosa becomes intestinal metaplasia, and from the intestinal metaplasia, the intestinal type of gastric cancer occurs. And recently, many molecular classification of gastric cancers is suggested, such as the TCJ classification. And then we can have a question: what's the relationship to the background of mucosa of this molecular subtype? The most famous molecular subtype of gastric cancer is microsatellite hepatocellular cancer. It is about 10% of gastric cancer, and frequent in older age, intestinal type gastric cancer, and the loss of stomach. I planned a study to identify the characteristic of background mucosa of MSI type gastric cancer, and I wanted to find the clues about the carcinogenesis of MSI gastric cancer. So, I select the tumor with a size of 4 centimeters or less, and about 1,305 cases. And I reviewed each slide of the cancer background mucosa, and I defined the molecular type with the immunohistochemistry. Actually, in stomach, there are a very diverse type of background mucosa because the native gland is different according to their location of the stomach, and the atrophic type is different as I show you previous. Non-metastatic atrophy and different type of intestinal metaplasia and pseudo metaplasia. It also causes spam. So I classified the background mucosa type with 2 parameters. First, tumor location, cardia, and high and mid body, including fundus, and low body and angle and anatomy. And the second parameter is atrophic types of atrophy change. No atrophy, non-metaplastic atrophy, intestinal metaplasia, and I subdivide this intestinal metaplasia in complete type and complete type. And I determine the molecular type with the immunochemistry for MLH1. Actually, if we determine the MSI type gastric cancer, we should use PCR or immunochemistry for the 4 mismatch repair proteins. But as you can see, the result of this paper, but immunostain for MLH1 can reflect about 90% of MSI high MSI positive cancer, so it can be used as a surrogate method. It is the result of my study. The MS type gastric cancer was most prevalent in Antrum. So in Antrum gastric cancer, about 17% of gastric cancer is MSI positive. And then I focused on the enteral gastric cancer. In enteral gastric cancer, I classified the atrophic types of the background mucosa. In the background mucosa type, only the incomplete type of intestinal metaplasia is related to MS type cancer. The complete type intestinal metaplasia didn't show the relationship. So I think the incomplete type of intestinal metaplasia is related to MS type cancer. So I do CDN microarray for 4 types of mucosal tissue: antrum, no atrophy, antrum with intestinal metaplasia, body, no atrophy, body with intestinal metaplasia. I cannot subdivide this intestinal metaplasia into incomplete and complete type because I should use the fresh frozen tissue. As a result, the differentially expressed genes in antrum intestinal metacases enriched with highly expressed genes in MS type gastric cancer. If we make a more direct and close relationship between MS type and intestinal metaplasia, we should do more comprehensive molecular study. But this is only the preliminary data. Right? So we should need more further study. This is conclusion. MS type gastric cancer have a distinct background mucosa type. The MS type gastric cancer were related to the presence of incomplete type of intestinal metaplasia, and the gene expression patterns are correlated between MS type gastric cancer and antrum intestinal metaplasia. And I think these findings can provide clues to the carcinogenesis of MS type gastric cancer. Thank you for
Thank you, Professor Group, for saving our lunch time. Is there any question or comment? I will ask one question. Why do you interested only in this MSI? There is several other types, but you only interested in focusing on this type. Is there any reason or?
Actually, about the molecular type of gastric cancer, in TCJ there are 4 molecular types, but GS and CIN type is to comprehensive molecular analysis, such as exome sequencing or RNA sequencing. MSI positive type and EV type can be determined with simple scanning method. Sorry. But till now, in EBV positive type gastric cancer, the carcinogenic pathway or carcinogenic gene has not approved, discovered. So only the MS type gastric cancer the carcinogenicity gene is discovered in MSI gastric cancer, the mismatch repair protein. So I focused on this MSI.
Let me confirm that you use the resected material, resected gas mucosa, I think. Am I right?
Yeah.
Yes. And then, but if the samples should have cancers. Am I right?
No.
Maybe you use rejected specimens.
Yeah.
So the reason for the rejection is a cancer or something? I don't know. Profit block means that of the rejected specimen. The reason for rejection is that they should have cancer. Gastric cancer?
Do you mean this molecular analysis?
Yes, yes, yes.
No, that is a fresh frozen tissue from the gastric specimen, and I take the tissue enough distance from the gastric cancer, so I think there is no contamination.
I know, but that whole specimen contains the cancer. I think that you pay attention that your presentation is there. Intestinal metaplasia, and especially in the antrum, is related to the MSI.
Yeah.
But some patients have cancer in other regions. I guess you pick up the mucosa from the antrum, but
I take the fresh tissue from one area, and I make a paraffin block at the same area, and I confirm the paraffin block HE, there is no cancer and only.
But yes, my question is that you're researching on the intestinal metaplasia and antrum is very interesting, but actually the patient have cancer at the other region, I guess.
You mean the other part?
Yes.
Maybe there is a cancer.
So the major reason for the developing cancer for the patient, for this patient is not MSI high. I don't know. Sorry.
I can't do that.
Any other question or comment?
How about the complete idol? This one is you mean the incomplete time is all just a precancerous potential? Complete idol.
Actually, the intestinal metaplasia has a risk factor for getting cancer, but among the intestinal metaplasia, the incomplete type of intestinal metaplasia has more high risk of getting cancer to the front.
Okay, thank you, Professor Wu, and thank you all of the speaker of this session and active participation from the audience. I close this session. Thank you.
A certificate of appreciation will be given to the Professor Boku and Professor Zhang. Now we have time for taking picture. All speakers and all chairmen and all attendees, please come to the stage. Outside the room, the lunchbox is prepared. Please enjoy until 2 p.m.
수정. 네네. 다시 보내드릴게요. 네네.
아, 마이크가 어디서? 거기요, 선생님, 지금. 방금. 선생님, 여기도 그러는 것 같은데요? 그죠? 지금 말할 때. 아, 이렇게요? 이렇게? 근데 이러면 떨어지는데? 그러면, 안 된다. 네, 잘 안 돼요. 근데 이렇게 하면 그 중심이 안 맞아가지고. 아니면은 간섭. 뒤로?
얘가 지금 이쪽을 향해가지고 나는 것 같거든요. 아니면
이거 맞춰놓은 건데? 괜찮겠죠, 뭐. 안녕하세요. 안녕하세요. 소영 어때? 하울링? 좀 있잖아요. 똑같은데?
얘를 뒤로 더 살짝.
이렇게 할까요? 좀 괜찮잖아요?
그죠? 그게 괜찮아요.
그럼 요 방향으로 할게요, 선생님. 그러면은 선생님 그거 카메라 되나 한 번만. 이것도 보이죠? 네, 요렇게 그러면. 너무 빠르게요?
안에 있는 거예요? 안에서만 네, 안에서만. 근데 오해 있을 거예요. 이렇게 갔다 왔다.
Good afternoon, everybody. I hope you enjoy the lunch. There is a quite cold, but although it's very cold weather, I really appreciate, international speakers from Japan. Thank you so much again. And then it's my great honor and pleasure to introduce Professor Emeritus Togo, College of Medicine, with Professor Mitsuru Sasako. I don't have to introduce him because he is so world famous, and you know well already. But I remember, Professor Sasako visited this institute just 11 years ago. Do you remember? 2012, December, you visited National Cancer Center and then did the live surgery for the advanced cancer. And then very impressed. I was very impressed that he asked about the patient condition after he returned to the Japan several times by mail. So I realized how much Professor Sasako is taking care of the patient with a heart problem. So I really appreciate his lifelong devotion to the research, but also for the patient care. For every patient he operated, how happy they were. He is currently a chairperson of the board of the director of the Yodogawa Christian Hospital and the Professor Emeritus in Nobel College of Medicine, and he was a past president, a past chairman of the stomach cancer group of JPO, and then he was born on July 20, 1950, at the Nishinomiya, Japan, and grown up in Kobe. And then graduated from Tokyo University School of Medicine in 1976, and then specialized in upper GI surgery and surgical oncology, as you know. And he spent 20 years at National Cancer Center Hospital in Tokyo and established a method and system of evaluating the oncological surgical procedures. I think it's a main great contribution. And he contributed enormously the globalization of the B2 surgery for potentially curable gastric cancer. He performed the gastric cancer surgery in more than 15 countries in the world to teach how to carry out B2 surgery efficiently. So he was one of pioneers who realized that telling the truth to the patients and real informed consent in Japanese medical practice. And so today we will listen to his lecture about the history of clinical trials in gastric cancer surgery and multidisciplinary treatment. Ladies and gentlemen, please give him a big round of applause, Professor Sasako.
Thank you very much for your kind introduction, Professor Kim. So nowadays my role is talking about history in many meetings. So when we started talking about the gastric cancer surgery with Western people, at that time, majority of our patients, nearly half, were stage 1 patients in Japan. However, it's the opposite. Stage 4 are more than half in the United States. This is the stage distribution and also the 5-year survival rate. And even at that period, even stage 1 patient in the United States has 5-year survival rate of 50%. Large difference between these two figures and our National Cancer Center Hospital data and USA data from Scott Fundau paper. Why such large difference? So both of us, Western people and Japanese people, thought, and some Western people say that gastric cancer is different between the West and the East. But actually, there is few reports supporting this opinion. But on the other hand, there are some studies showing little difference of biology between the areas. We made that kind of paper together with Western researchers. And the patients are different. This is true. Maybe age, BMI, comorbidity, and these factors affected the operative mortality and morbidity. And treatments are different. That's what we emphasize to Western surgeons. And some people say that was because of stage migration, because you take many lymph nodes, and that causes better stage and stage classification that leads to the stage specific better survival. This is the slide. This is Norwegian, Sweden surgeon, a big, tall, and this is British surgeon, big. And this one is Professor Fukagawa. As a Japanese, he was big, but compared with this person, small. And this is typical Japanese slim person. And this is slide explains the stage classification. If we have two classes like this, and this was based on the results of entrance exam, and some students of maybe IQ in between classified in this, and some a little bit in this average student. And I can change the class average in both classes just by sending these students to this class. This class become only very intelligent student, and these students can raise the average of the average class. So this is the theory of stage migration. And before the first scientific approach to this issue, Japanese old surgeons just told this theory. Gastric cancer cannot be cured without complete removal of the tumor because we didn't have good drug at that time. All potentially metastatic nodes should be therefore dissected. The Western logics at that time, if dissection cannot lead to cure, no use of performing it. If cured, the gastric cancers are different from ours, they say, and better stage specific results are due to stage migration. So I showed them the effect of dissection. Before this paper, Japanese said such a percent of lymph nodes are involved. That is the only base. But I calculate the probability of metastasis in each lymph node station and multiply the 5-year survival rate of those who had node metastasis in each station. So that showed directly the effect of dissection. And for example, the antral tumor incidence of nodal metastasis highest in the infrapyloric area. But in this area, even the patient having metastasis, their 5-year survival rate is 46%. So by multiplying the left figures by right figures, I can elucidate the index, a kind of index. That's the benefit index of lymph node dissection. Calculate, we could make a figure like this. The second step is more scientific method. That is randomized control trial. Before we started this in the Netherlands and the UK, there were two small sample size studies. One is South African, the other one is a Hong Kong trial. Both are very small sample size. And there is no clinical hypothesis, and sample size was not calculated properly. And the South African study showed higher morbidity, but no survival benefit. And Hong Kong study even the worst survival for D3. In that case, D3 is a former D3. That means D2 plus number 12 and 13. And so Van der Velde from Leiden University, he said that it is needed to evaluate D2 in a large scale RCT. And he told me that, could you kindly come to Holland to carry out RCT on D2? Oops. So I agreed to go there. And so before we started the Dutch study, they have already started, Professor Kushiri started the MRC trial. And this MRC trial included 400 patients, the Netherlands Dutch study, 711 patients. But hospital volume was very low, 1 patient per year, per hospital per year average. So this is a scheme. So as at that time, we didn't perform staging laparoscopy. Many patients with advanced cancer had peritoneal seeding when we open the stomach. So we have to include these non-curative cases in the randomization. So we estimated we need about 1,000 patients altogether because some percent of patients were incurable. The first patient was randomized in this study. This could be a challenge or reckless performance. So when the trial was started, there was only one Dutch surgeon who knew what was D2 and had carried out D2 for about 20 patients. And no one else had never experienced D2. No feasibility study was carried out in this Dutch study. So the first patient could be randomized because I operated on that patient. So from scientific and ethical point of view, this is not anymore allowed. So in the Dutch study, we carried out P3 study without P2. But we made a little bit effort to assure some quality of treatment. So quality control was done in several ways. As a supervisor, I demonstrated 27 D2 gastrectomies. I guide 6 D2 gastrectomy by Dutch surgeons and lecture of D2 technique using D2 video in a Japanese patient, and all participants received this video. And I took also, during my stay at the beginning of this study in the Netherlands, I took a video of D2 surgery in a Dutch patient. And also I distributed this video. And also we made a booklet showing anatomy and technique of D2. But eventually we were very much shocked with the results of mortality. In the MRC trial, the mortality of D2 was 10%, and same was 10% in the Dutch study. So D1 showed only 4% mortality, and D2 nearly 10% mortality. So survival curve at the beginning and the handicap was made. And the D2 catch up in the middle after 4 years, but this difference was not become significant for some period. And this slide shows the mortality and hospital volume. As the Hong Kong study and MRC study, Dutch study, Italian study, this was phase 2 study. The only phase 2 study about D2 was performed by Italian group. And this was retrospective case series, and this was from UK, and this was from Italy. And very, very much high mortality was recorded in the MRC and Dutch study, and the hospital volume in these series were the lowest in these 2 studies. So Mary Brennan wrote an editorial after the first results of that study came out in the New England Journal of Medicine. Small hospital volume, insufficient quality control, and eventually they compared that D1 plus versus D2 minus. And D2 total gastrectomy in the Dutch study required a pancreatic splenectomy. This was standard in 1970s or early 1980s in Japan. And reliable results for specialist centers in the West where operative mortality was not that high. As conclusion, this study in which unaccustomed surgeons performed D2 just harmed enrolled patients, cynically pointed out that this study contributed to prove the difficulty of clinical studies in GI cancer surgery. So factors which may influence the morbidity and mortality after D2 patients, of course, we know that the obese patients, they have higher morbidity. And the tumor, maybe, because the location of upper part requires total gastrectomy. So total gastrectomy causes a little bit more morbidity than distal gastrectomy. Of course, procedures, especially combined resection of pancreas and spleen. And hospital volume and surgeon's volume is very important factor. So another point is mortality after postoperative major complications are very different. In low incidence countries like the Netherlands, once leakage occurs, for more than 40% of patients died. But at the same period in National Cancer Center Hospital, mortality after leakage was 14%, but it may have become much lower after this period. So quality of postoperative care does matter. In the Dutch trial, effort was made to control the quality of surgery, but not that of postoperative care. Each hospital had a quite small number of cases annually, so that means learning how to manage complications was not possible. In spite of several critical points, this Dutch study was the first courageous challenge, and it was a big step forward. And we could learn a lot from this study. People were convinced of the possibility of randomized trials in the field of GI cancer surgery. From one trial, we can produce many accompanying scientific papers. Even post-hoc studies may be more reliable than single institutional retrospective studies. Knowledge about how to make quality control and quality assurance in surgical trials. So the Dutch study stimulated many surgeons in various countries. We, Japanese surgeons, stimulated very much. So that's why I started JCOG Gastric Cancer Study Group study. We used to have that study, but very much different structure we started to have. And one is Italian group, the Professor De Giulio, he has passed away recently, but anyway, he started phase 2 and then phase 3. And Dr. Wu in Taiwan started D1 versus D2-3 study. So Japanese surgeons got confident that we could do better. We have JCOG, which has full capacity to perform any kind of clinical studies with independent data center, hiring several statisticians. Certain number of high volume centers which has uniform quality in gastric cancer treatment. We prepared with all that we learned from the Dutch study. So this is the structure of JCOG 9501 comparing D2 versus D2 plus standard parotid node dissection. So in this study, we used 523 patients, but mortality in each group was just below 1%. But unfortunately, unlike our expectation, D2 plus Pandi showed completely the same results as D2. But this study was published in the New England Journal of Medicine in 2008. Although negative study in uncommon cancer in the United States, New England Journal of Medicine accepted this paper because of high quality in many aspects of trial and good survival results. This is another study we started at the same time, comparing left thoracoabdominal approach versus abdominal transhiatal approach for gastric cancer invading the cardiac. This approach and this approach. And thoracoabdominal approach had higher complication rate and even the worst survival rate. But before we get the results of Jacob 9501, the Taiwan group published in the Lancet Oncology that the results of Taiwanese study. And this is the only study who showed the benefit, proved the benefit of D2 over D1. This was single or just a few hospitals patients, so they have good quality and no hospital deaths, and the survival was like this. Quality issues, specific surgical trials, we have to take care. So quality of given treatment, reproducibility, homogeneity, verifiability, and patient's factors. Of course, we may exclude some extreme patients. In the laparoscopic study, we excluded some very obese patients. So such exclusion might be necessary in some cases. The surgeon's factor, we have to take care who can join this multi-center study. And quality should be included post-operative care. So we need some high volume hospital. Blinding is impossible in surgical studies. So they're easily affected by personal preference or prejudice of treatment. And possible method of auditing the treatment is also very important. We developed in the JACOB group, and some is a videotape recording. This one is possible in the laparoscopic surgery. An on-site visit by referees, this was unrealistic. And a close-up photograph of the operation field after dissection, close assessment of resected material, which requires a lot of effort for pathologists, and feedback the results of the operators improve the quality. So this is, for example, this was case of the colorectal cancer study. The pictures should be taken in the same area and sent to the study office. And we carried out another study, and after 2000, this is a study about splenectomy and comparing splenectomy and spleen preservation to orgasectomy. And we proved that the spleen preservation can be non-inferior to splenectomy case. So this is the first our study of non-inferiority study. So similar results can be obtained with less invasive treatment. Similar results can be obtained by treatment providing better quality of life. Similar results can be obtained with harmless drug. And in JCOG 0110, preservation of spleen could show similar overall survival with much less morbidity. And in case of laparoscopic surgery, we perform because it's before 2010. So we have to carefully confirm the safety of this procedure. So we carried out first phase 2 study of laparoscopic distal gastrectomy. And then after confirming the safety, we moved to the phase 3 study. And we need about 900 patients, and only some patients underwent different way down allocated arms. And we could confirm the non-inferiority of the laparoscopic distal gastrectomy to open distal gastrectomy. Similar one was carried out in this country, and the results were the same. And this is a study about thoraxectomy, because when I became surgeons, standard D2 gastrectomy, including brachectomy, omentectomy, and stomach resection with D2 dissection. But some doctors, even at that time in Japan, skipped the brachectomy. So we have to compare whether brachectomy showed a better survival than non-brachectomy case. We enrolled 1,204 patients. This is the largest study so far ever we carried out in JCOG stomach cancer study group. And this slide shows the non-inferiority of non-brachectomy procedure. So now I will talk about the multidisciplinary treatment of gastric cancer. Before 2000, there was no solid standard treatment in this field, and several metastases only suggested efficacy of adjuvant chemotherapy. So this is the one of meta-analysis and showing much better results for adjuvant groups. But as you see here, regimens are very much different each other, and we don't know which regimen we should give. And when we think the basic concept of adjuvant treatment, so we have to know that what is recurrence of cancer. When invisible metastasis or dormant tumor cells, the initial treatment become clinically or radiologically recognizable, we call them recurrence. Sometimes recurrent tumors develop metastasis to other sites or become systemic cancer involving many organs in the body. Not only patients, but also doctors are afraid of such latent cancers still several years until several years will pass. Nature of classic type anti-cancer drugs is cytotoxic. Most of them inhibit or impede cell cycles. They don't select cells, not cancer cell specific. The higher the cell proliferative activity, the severe damage they get. For example, the bone marrow, or mucosa, on the hair valve, and so on. The organs which metastasize drug or accumulated drugs, metabolized drug or accumulated drugs get injured. Usually these drugs cause some adverse effect. Even in case where patients don't feel any symptoms, some adverse effects are happening secretly, such as bone marrow suppression Long-term administration may cause drug resistance, and after recurrence, cancer cells are resistant to drugs used in the adjuvant therapy. Therefore, adjuvant therapy should not be given without solid evidence of its efficacy. But why we do immediately after surgery? Tumor burden as minimum after surgery, soon after surgery. So we recommend in the Japanese guideline before 6 months after 6 weeks after surgery. The smaller the tumor burden, the more efficient the chemotherapy due to minimum potential of heterogeneity. More probability of complete regression when the tumor burden is minimum, but it's not still not evident. Even for minimum burden, cancer cells will not die by drugs having no sensitivity to these cells. We should understand that each patient has not latent cancer cells having certain percent of recurrence, but certain percent of patients have latent cancer cells having very high probability of recurrence. So the principle of adjuvant treatment, the absolute principle in medicine, is not to do anything potentially harmful, but unnecessary for patients. This is same in each kind of method of treating cancer patients: surgery, chemotherapy, and radiotherapy. Is it nonsense to perform a larger RCT involving thousands of patients to prove a few percent difference? Huge number of patients undergo. If we carry out some big study, including 5,000 patients, to show 5% of difference, the majority, many of patients undergo unnecessary treatment. We should spend more money to find out good way of selecting patients who really need treatment. We practice medicine not for us, but for patients. How to improve efficacy of adjuvant treatment? One is selection of high-risk patients, detection of latent cancer cells like lavage cytology. This has become standard practice in Japan. And circulating DNA detection and detection of many studies show some meaning of detection of circulating tumor DNA. And individualization of suitable drugs is also very important. Genomic analysis to find out driving genes, develop a good drug for each driving gene. But ideally, develop almighty drugs, but it's not realistic. There are 3 epoch-making studies in early 2000. One is intergroup study 0116 in the United States. 2006 MAGIC study in UK, and 2007. All these papers are published in New England Journal of Medicine, ACTDC in Japan. So this is the scheme of intergroup study. This was a study comparing observation surgery alone versus postoperative adjuvant chemoradiation. And in this study, postoperative chemoradiation, the radiation field includes so-called gastric bed and both resection margin. So proximal and distal margin. So many cases at the duodenal stump and anastomotic site of the esophagus. Just a part of palatic node area were covered, and mainly 16A2 lateral area. Chemotherapy was 5-FU plus recurrent very classic type chemotherapy. And the D2 dissection was recommended as standard surgical procedure. The primary endpoint, disease-free survival, show big difference, and overall survival as well. But against this study, many critical issues occurred. Only 10% of patients underwent recommended D2, and the majority underwent D1 or D0. The revision of irradiation plan was needed in 35% of cases. Not small number of patients who received the irradiation have lost their left renal function. Actually, the proportion who underwent D2 was here, 10%, and 36% D1, and more than half of patients underwent even less than D1. And then among D0 patients, chemoradiation was very effective. Same in D1 group, but there was no effect of chemoradiation in patients who underwent D2 dissection. So important message from this study, first one is gastric cancer cannot be cured without sufficient local control. And the second one, the quality control of surgical treatment is of paramount importance in adjuvant treatment. And the next study is neoadjuvant chemotherapy. Maybe we should say perioperative chemotherapy before and after surgery. This is MAGIC study. And this slide shows difference between surgery alone and chemosurgery chemo. Large difference. And this is overall survival. The same big difference. In terms of 5-year survival rate, 13% improvement was seen in the chemosurgery chemo group. And looking back to the Japanese practice in 1980s, in 1980s, post-operative adjuvant chemotherapy started to be recognized as a routine practice in Japan based on several subgroup analysis of RCTs. Even the ISAC, this is the precursor group of Jacob's stomach cancer study group, did not agree to perform RCTs with surgery alone as control arm in 1980s. Many Japanese surgeons claimed the superiority of adjuvant chemotherapy based on meta-analysis, gathering RCTs of quite low quality. So I wrote a paper. I claimed that adjuvant chemotherapy for gastric cancer should be fundamentally reconsidered. And it's a Japanese paper because this is a message to Japanese doctors. And return to the starting point I praised. So in the next trial, Jacob started to return to the starting point, accepting uncertainty of adjuvant chemotherapy for all curatively resected gastric cancer patients. Jacob 92061 is T2 tumor, and 92062 is T3, T4 tumors. And chemotherapy was in this relatively early stage tumor, UFT. And this more advanced disease, 3 types of chemotherapy was given, IP therapy immediate after surgery, and 5-FU cisplatin IV, and UFT. And both studies was negative. So majority of Japanese surgeons started to accept uncertainty. That's why we could carry out FDC study. And this study was comparing surgery alone versus S1 monotherapy. And as you know, S1 monotherapy showed significant benefit over surgery alone. And then next step is another study, JACRO study, S1 plus docetaxel comparing with S1 monotherapy. And that showed the benefit of S1 plus docetaxel. It's now stage 3 patient, S1 plus docetaxel has become standard. But peculiar phenomenon was seen in stage 3B. But I don't know why this happened. And for stage 2 patient, we had already good result with TS1. So we compared 4 courses versus 8 courses of S1 monotherapy, because in the colorectal cancer, many studies was carrying out comparing 3 months donation administration versus 6 months administration and so on. But we stopped this study in the middle because of very low futility of showing the non-inferiority of 4 courses. So we concluded that we should give 8 courses of TS1 even for stage 2 patient. And this flow of studies on perioperative chemotherapy were different in each country content. The European continent, they started with MAGIC study, which include perioperative chemotherapy, neoadjuvant surgery, and postoperative. And so actually, they carried out FLOAT4 study comparing different regimens, but they never tried to compare perioperative and postoperative alone. But in Asia, our study, JCOG 0501, could not show the benefit of giving neoadjuvant, so before operation. So we think that still it's an open question. So now maybe in Europe, it is not easy to go back to the comparison. So this is a FLOAT study. They compare only FLOAT regimen and the ECF, ECX, so MAGIC regimen. And it shows FLOAT study is better, regimen is better, but there was no comparison between the perioperative and postoperative alone. And this is a resolved study from China, and they show some difference between 2 regimens, but there was no actual comparison between SOX, D2 SOX, and D2 SOX, almost same survival curves. And in Korea, they made a prodigy study. But as you see, this large down was recognizing that when they opened the stomach, some cases already had metastasis. So unfair comparison maybe. So if we regard this kind of phenomenon as progression, that can be a different story. So this is the scheme of JCOG 0501. There was no difference. And even the progression-free survival as well. But if we define that when we open the stomach in the surgery first group, if it's defined as recurrence, that curves is similar to prodigy study. So this curves will become this curve. So definition, the difference, but you see, there are overall survival curve is here. And so this curve becomes this one. So the definition of recurrence is very delicate issue. So we think that still we're not sure that neoadjuvant setting, perioperative setting is better than postoperative alone. So we are now carrying out in the JACO group comparing upfront surgery group and this chemo group. I think this slide shows the members, a little bit old members of JACO group. But to establish a new standard that a good team of doctors having enough experience and sufficient knowledge about medical statistics and clinical studies is essential. I acknowledge to all members of stomach cancer study group of JACO. All what I have done is for patients. Although each step is small and slow, we should keep on going. The patient sitting in front of you, maybe yourself in the future. Thank you very much for your kind attention.
Thank you very much. The full overview of the very important trial for the treatment of breast cancer for maybe 40 years. So it's a very special lecture, but if you allow, maybe we could have some questions from the floor. All right, so maybe if everybody should agree that we have our role as a surgeon only for the patient. That is the science in the mind, scientific ideas. So we should evaluate and validate what is better, what is better option for the patient. That's our ultimate goal. So we reminded of very important today. Yeah. So please give him a big applause again.
Okay. We'll move to the next section. Next session is the surgical oncology session. Professor Michiru, I'm sorry. Yes, Professor Michiru Sasako will chair this session. Professor, please.
We have 4 speakers. And Professor Kawashima will talk, but sadly, it's straightforward. Although the number of stage 1 patients increasing dramatically and very much, but still 7% of patients are the number of stage 4 rather constant. So I think it is very well. Thanks, Kim.
Thank you very much, Professor Sasako. It's very tough to talk my speech after the very impressive and emotional his lecture. And I'd like to express my sincere appreciation to Professor Yang Kim for inviting me to this wonderful forum. I'll talk about surgical treatment for stage 4 gastric cancer. As you know, the Japanese guidelines has been updated to 6th edition in 2021. The English version has been published last year. This shows the treatment algorithm. Of course, most of the M1 disease, chemotherapy is recommended as standard treatment. This recommendation is based on the result of Regatta trial. Regatta trial was designed to investigate the superiority of volume reduction surgery to chemotherapy alone in advanced gastric cancer with single non-curable factor. Unfortunately, superiority of volume reduction surgery was not demonstrated. So gastrectomy cannot be justified for treatment of patients with these tumors. However, there was a heterogeneity of results according to tumor location. Hazard ratio for U region tumor is 2.23, while in the M region, hazard ratio was 0.95, and in L region, 0.63. So gastrectomy seems to have some merit in tumors with L region. I have recently published a more detailed subgroup analysis of Regatta trial. There was a heterogeneity between the country as well. Gastrectomy plus chemotherapy was apparently worse in Japan, while the survival were almost same in Korea. This shows the survival according to the surgical treatment. Survival in patients received total gastrectomy was obviously worse than chemotherapy alone. On the contrary, survival in patients received distal gastrectomy in the red line appears to be a little bit better than chemotherapy alone arm. This trend is more obvious in Korea. So patients with distal tumor may have a merit by volume reduction surgery. It is still an open question. Then I'd like to move the topics for CY1. In the current version of guideline, there is a CQ for CY1 disease. CQ30 is combination therapy of fluoropyrimidine and platinum recommended for resected gastric cancer of CY1. Recommendation is not using combination therapy of fluoropyrimidine and platinum for resected gastric cancer of CY1 is weekly recommended. S1 monotherapy is weekly recommended for resected gastric cancer of CY1. This recommendation is based on the retrospective study conducted in Jacob stomach cancer study group by Professor Boku. This slide shows the comparison of overall survival among adjuvant chemotherapy regimen. There was no significant difference of survival between S1 and the S1 combination chemotherapy. In addition, in the similar retrospective study comparing initial treatment, chemotherapy over surgery, there was no significant difference regardless of the initial treatment. So for CY1 alone disease, upfront surgery and adjuvant S1 monotherapy is recommended. However, in patients converted to CY0 after induction chemotherapy, the survival was significantly better than upfront surgery. Similar results have been published from Peking University. In patients with CY1, OS and PFS were compared according to the initial treatment. There were no significant difference in OS and PFS between initial surgery group and initial chemotherapy group. Only patients converted to CY0 demonstrated a favorable overall survival compared to surgery initial group. So if CY1 is diagnosed during surgery, upfront surgery followed by chemotherapy may be a standard. However, if CY1 is diagnosed in staging laparoscopy, induction chemotherapy should be performed and surgery will be considered only in patients whose CY1 turned to be negative. Then I'd like to move the topic for oligometastasis. As you know, there is no global consensus for oligometastasis in gastric cancer. Surgeons and medical oncologists in Netherlands, Richard Hillengasberg and Hanneke Langhaven, conducted a study group called oligometastatic esophagogastric cancer (OMEC) study group and established the definition of oligometastasis esophagogastric cancer. Most studies consider a maximum of one involved organ with or without the retroperitoneal lymph nodes with 3 or fewer metastases as oligometastatic disease. In the OMEC project, they achieved consensus on the definition of oligometastatic disease being 3 or fewer distant metastases in a maximum of one organ or one involved extraregional lymph node station. They included lung and adrenal gland and bone metastasis as well as liver metastasis for oligometastasis. This demonstrates the participating center and the overview of OMEC project. Investigators from most major countries in Europe are participating in this project. OMEC project consists from 5 steps. OMEC 1 is a systematic review. OMEC 2 is a multidisciplinary tumor board discussion. OMEC 3 is a Delphi round and consensus meeting. OMEC 4 is a publication of European consensus. And finally, OMEC 5 is a clinical trial. This is a publication of consensus meeting. Oligometastasis disease, OMD, was considered in patients with metastatic esophagogastric cancer limited to one organ with 3 metastases or one extraregional lymph node station. In addition, OMD was considered in patients without progression at restaging after systemic therapy. For patients with synchronous or metachronous OMD with a disease-free interval 2 years, systemic therapy followed by restaging to consider local treatment was considered as treatment. For metachronous OMD with a disease-free interval more than 2 years, either upfront local treatment or systemic treatment followed by restaging was considered as treatment. This is a European consensus for definition and treatment of oligometastatic esophagogastric cancer. Japanese condition is a little bit different. In the Japanese guideline, there is a CQ for oligometastasis. CQ10 is surgical treatment for oligometastasis recommended. Recommendation is surgical resection after neoadjuvant chemotherapy is weekly recommended for a small number of paraortic lymph node metastases confined to number 16A2B1. In addition, surgical resection is weekly recommended for solitary liver metastasis without other incurable factors. This recommendation of the lymph node metastasis is based on the results of JCOG 0405 trial, which evaluates the efficacy of neoadjuvant chemotherapy consistent with S1 and cisplatin for extensive nodal disease. This slide shows the definition of extensive nodal disease. We defined bulky N2 and metastasis in paraortic lymph node metastasis as extensive lymph node metastasis. 3-year survival rate in the historical control was just 15%. The results of the JCOG 0405 trial was wonderful. 5-year survival rate was as high as 53%. And in the subgroup analysis, in the paraortic lymph node metastasis alone group, 5-year survival rate was around 60%. So Japanese guidelines recommend paraortic lymph node dissection after neoadjuvant chemotherapy. We further evaluated the efficacy of triplet regimen consisted from docetaxel, oxaliplatin, and S1, called DOS regimen in extensive nodal disease. Primary endpoint was a histological response rate equal to or greater than grade 2. The result has been demonstrated in this year's ASCO GI meeting, and the paper has been accepted in gastric cancer and published very soon. Pathological response rate was 56.5%, and this study met the primary endpoint. Surprisingly, complete pathological response was 23.9%. So the DOS regimen will be the new standard for the extensive nodal disease. As for hepatic metastasis, Professor Kodera at Nagoya University has reviewed about the surgery for stage 4 gastric cancer. He summarized 4 recently published Asian retrospective studies of surgically treated hepatic metastasis from gastric cancer, including multiple liver metastasis. Surprisingly, 5-year survival rate was more than 30% in all studies. This is much better than chemotherapy alone. In addition, systematic review had been published from Imperial College by Shiras. Surgical resection may have merit for improving survival, especially for solitary metastasis. Hazard ratio of surgical resection was 0.50. So we recommend hepatic resection for solitary liver metastasis. This shows the comparison of initial treatment for multiple liver metastases of 3 or less from our cancer center. Hepatectomy seems to be a little bit inferior to chemotherapy. However, survival in patients received surgery after chemotherapy was better than the other treatment. So we concluded that although hepatectomy is not recommended as the initial therapy, it prolonged the survival of patients with tumors controlled using systemic chemotherapy. With regard to post-operative, I'm sorry. Oh, sorry. With regard to post-operative adjuvant chemotherapy after resection of oligometastasis, Professor Bock also conducted a retrospective cohort study comparing the survival with or without adjuvant chemotherapy. Favorable survival was observed in patients with post-operative adjuvant chemotherapy than in patients without it. So post-operative chemotherapy may be recommended after curative resection of oligometastasis. JCOG have planned a collaborative research with EORTC for hepatic metastasis from gastric cancer. At first, we made a survey of clinical practice for liver metastasis from gastric cancer in Europe and in Japan. The clinical practice appears to be not so much different between Europe and Japan in both synchronous solitary liver metastasis and metachronous 2 region of liver metastasis. Chemotherapy followed by hepatectomy appears to be the most commonly performed procedures. So if the number of metastases is limited, hepatectomy should be considered. In order to conduct a prospective trial, the definition of resectability is of most importance because standard treatment is different according to the resectability. JCOG tried to define the resectability of stage 4 gastric cancer classified into resectable, borderline resectable, and unresectable, based on the consensus of JCOG investigators from 64 high-volume centers in Japan. For peritoneal metastasis, P1A is considered to be resectable, while P1B and C is regarded as unresectable. This slide shows the classification of peritoneal metastasis in Japanese classification. P1A is defined as localized metastasis around the stomach. This tumor is defined as resectable. All of the other metastases are considered to be unresectable. There is no borderline resectable tumors. As for lymph node metastasis, paraortic lymph node metastasis confined at number 16A to B1 is regarded as borderline resectable, and the other distant lymph node metastasis is considered to be unresectable. This slide demonstrates a schematic location of paraortic lymph node. Number 16A2 and B1 are considered to be borderline resectable, while A1 and B2 are considered to be unresectable. For hepatic metastasis, we consider that the metastasis less than or equal to 3 are considered to be borderline resectable, and more than 3 is considered to be unresectable. We think these borderline resectable tumors are a good candidate for clinical trials of oligometastasis since the treatment strategy may not be different. Only oligometastatic disease in paraortic lymph node and liver metastasis would be the subject for oligometastatic trial. Renaissance trial is a well-known randomized control trial for evaluating the role of surgery in oligometastasis from gastric cancer. Inclusion criteria is almost same as OMEC project, except for peritoneal disease with PCI less than 7. However, the study group has recently decided to terminate patient recruitment and proceed to statistical analysis. One of the PI of this study, Stefan Menik, told me 3 weeks ago in Seoul that patient accrual has been extremely poor in these 2 years. One of the reasons of slow accrual is the change of the guideline due to the change of the guidelines. In ESMO guidelines published 2022, in surgery for metastatic gastric cancer, it is described that at the present time, data to support routine resection or ablation of oligometastasis are limited. Resection of metastasis cannot be recommended in general, but might be considered as an individual approach in highly selected cases with oligometastatic disease and response to chemotherapy. However, in the recently published, maybe a couple of months ago, guideline, German, Austrian, Swiss guideline, it is described that international data analysis show that surgical therapy for oligometastatic disease is increasingly perceived as a treatment option. The attitude for surgical resection is a bit different, despite that Professor Florian Lodek wrote both guidelines. After publishing these guidelines, investigators felt some difficulty to enroll patients into the Renaissance trial. They told me that is a major reason why. Another prospective trial for oligometastasis is a SURGE-GAST trial conducted in France. I heard that patient enrollment is also very poor. I think most of patients want to receive surgery if the tumor is resectable. So study comparing surgery and chemotherapy may be difficult to get the patient's agreement. In the OMEC project, as I mentioned before, OMEC5 is a prospective clinical trial on the treatment of oligometastasis. However, it is not yet started due to the lack of funds. So they are now discussing with URTC about the possibility of getting funds. And JCOG is now also discussing with URTC about the collaboration. Of course, study design should be initial chemotherapy followed by surgery, including metastatectomy. An important CQ in this condition is the length of preoperative treatment. So we will randomize patients into standard and longer period of preoperative treatment. PI will be the Professor Kinoshita at National Cancer Center East Hospital. We will be able to start this trial within the coming year because JCOG does not need the fund from the company. To get the fund from company is extremely difficult because the company does not have interest to this kind of the study. For unresectable tumor, palliative chemotherapy is considered to be a standard. And if the tumor responds very well to chemotherapy, conversion surgery can be considered. This slide demonstrates the concept of conversion surgery. Induction chemotherapy is performed to the patient with unresectable tumor such as distant lymph node metastasis, hepatic metastasis, peritoneal metastasis, and so on. If the tumor responds very well, surgery is planned with curative intent. This is conversion surgery. Professor Yoshida at Gifu University categorized stage 4 gastric cancer into 4 categories according to the metastatic site and prognosis of the patient. He pointed out category 2, 3, and part of category 4 will be a good candidate for conversion surgery. In Japanese guidelines, CQ11 is conversion surgery recommended. Recommendation is conversion surgery for patients with stage 4 gastric cancer is weekly recommended with the condition that chemotherapy provides a certain anti-tumor effect, the response is maintained, and R0 resection is possible. This recommendation is based on the international retrospective trial Combo GC1 in collaborating with Japan, Korea, and China. After conversion surgery, 3-year survival rate was around 50%. Survival was not so much different among the categories. However, survival in patients underwent R0 surgery was significantly better than in R1 and R2. 5-year survival rate was almost 50%. The role of conversion surgery is worth to evaluate in prospective randomized study. This is a planned study design of JCOG 2301. In patients with initially unresectable tumor, if tumor responds very well to chemotherapy plus minus immunotherapy and become potentially R0, patients receive staging laparoscopy and randomized into continuation of the chemotherapy or conversion surgery arm. As the survival rate is much higher, as Professor Bock mentioned this morning, after the immunotherapy era, after the introduction of immunotherapy, it is worth for performing randomized trial now. Ladies and gentlemen, I'd like to conclude my presentation as follows.
volume reduction surgery is not recommended for tumors with non-curable factor. For CY1, upfront surgery followed by S1 monotherapy is weekly recommended. Surgery after neoadjuvant chemotherapy is weekly recommended for lymph node and liver oligometastasis. Conversion surgery is also weekly recommended. But a prospective trial to evaluate the role of the surgery for oligometastasis and conversion surgery is of most importance. Thank you very much for your kind attention.
Thank you very much for the presentation. Now this paper is open for discussion. Who wants to ask questions?
Okay, thank you. So thank you very much for a very comprehensive review of the current status of the treatment for the stage 4 cancer. But maybe there are not so much lot of consensus, among the globally, because the pattern and of the treatment, and then the kind of argument about the kind of a different kind of a disease in the Caucasian or Asian or kind of a different type of the chemotherapy in the Europe and Asia is very complicated. So maybe it's very difficult to evaluate all those kind of results of the clinical trials, I think. So anyway, the REGATA trial I think is a very important trial to tell that, those kind of just a reduction, cytoreductive surgery does not work. So I just want to know that what is the situation though in Japan and the real world situation in the surgeons or any clinicians, maybe stick to those kind of result or guidelines, for Japanese guidelines into the practice. So because there are so many very conflicting data, so many very recently. And then there's the misunderstanding or confusion about the concept of those kind of treatment for this very difficult disease. So what do you think about that?
Yeah, thank you very much for your question. Actually, for patient, he can perform the chemotherapy, we have to follow the guidelines because they got the trial, the results of the trial. We do not perform the volume reduction surgery, only bypass surgery, and then proceed to the chemotherapy. And if the tumor responds very well, he has another chance for the conversion surgery. So we do not perform the volume reduction surgery. But if the patient cannot receive the chemotherapy, the situation is quite different. So sometimes patient cannot eat well, so we perform the volume reduction surgery and just observation after surgery. It sometimes happens, but if the patient can tolerate to the chemotherapy, the volume reduction surgery should not be performed, even the distal gastrectomy.
And okay, thank you very much. And I'm somewhat curious, about the situation about the kind of some molecular targeted therapy, the matching with the kind of a genomic or proteomic profiles of the cancer and the difficult disease in Japan. So maybe it's a future perspective because I think the gas cancer is like many other solid tumors. It's very heterogeneous actually, but our trials are just using a similar drug for every patient. Then maybe in the future, in near future, we need to find some molecular kind of those diversity of the cancers, and then we can tailor the treatment for the patients. At least for the after second line treatment, after first primary treatment. So I'm just curious in how much of those kind of patients are now enrolled to those kind of those matching trials in Japan. You have a Scrum trials, right?
But we do not attend, not involved in the Scrum trial. Only the National Cancer Center is the hospital.
Oh, really?
Yeah, I think it's Professor Book will answer to this question. If he's the right person, I think.
So maybe we need the kind of collaboration for, to resolve this very difficult fatal disease.
At present, the
So-
MSI is the only candidate for
Mm.
the treatment changing strategy. So in the MSI high patient, we have to reserve the stomach.
Mm.
Maybe it's possible.
So because, huge kind of bunch of, so many patients are now enrolled to the kind of some clinical trials of just new treatment after second line treatment. So maybe it's better to enroll the patients to those kind of some precision medicine trials rather than just doing a kind of testing those kind of very new drugs from many companies.
Yeah, I'll tell about the result of the Scrum project. For the gastric cancer patients, the 10% of the patients find a matched drug. And then single use of monotherapy of the such drug is administered into the such patient, and the response rate only 20%. So that means out of 100 patients, 2 responders. So there is now at the present, we precision medicine based on the genomic analysis is not successful for gastric cancer. But I think that so monotherapy doesn't work. So we should find the combination chemotherapy. Because so some pathway is cut by the one single drug, but another bypass pathway will be activated. Then we can see the change in the pathway change. We can add the next drug. Then that means such a chess or shogi. So and then we can change the drugs, seeing the movement of the cancer cells. Then so that is my dream and the dynamic. So yes, I call them dynamic precision medicine.
Dynamic, okay. Good. So anyway, in the Scrum trial, so if we think of the whole patients in Japan, how many patients are screened for those Scrum trials?
More than 2,000.
I mean the proportion of the whole patients.
That's
Overall,
very difficult.
I mean-
Very difficult to about. So maybe less than 5%.
Okay, so that's what I mean. So although actually the real, the patients who got the base benefit from this kind of precision medicine very limited, but I think it's very important to collaborate. As many as possible hospitals, and then as the Professor Boku told to us that we could develop some better kind of regimen of the combined therapy. Those kind of very active and collaborative effort must be done, I think, for the stage 4 breast cancer. That's what I'm telling. So what is your opinion, and then a kind of whole Japanese kind of perspective for those?
Yeah, it's a kind of a dream, but we need a fund. It's a huge fund even in the trial. It costs a lot, so we need much more money. So if possible, we can do it. Yeah.
Any other comment? The difficulty in gastric cancer is heterogeneity, and also mentioned about how to get the resistance to some drug. So still we have many steps.
That's right. Yeah.
Thank you very much.
Thank you very much.
Next speaker is Shigami. He's almost very famous surgeon, and his main interest in peritoneal surface gastric cancer. So he devoted for many years to cure peritoneal metastasis from gastric cancer.
Thank you for kind introduction. 안녕하세요. 동교대 학교의 이시감입니다. 초대해 주셔서 감사합니다. 다시 만나서 반갑습니다. I'm very happy to be back here after 4 years interval since the first forum here. I learned a lot from excellent lectures and I had a good time with young doctors. And I also enjoyed the great nature after the forum in Sulaxon. That's really nice. Today I'll give a talk on IP chemotherapy for peritoneal metastasis and then conversion surgery and IP for prevention of a new trial. As Professor Sasago mentioned, I have devoted myself to develop this kind of treatment for as long as 17 years. Let me start with my Let me start with my patient diagnosed with type of gastric cancer with peritoneal metastasis with ascites, hydronephrosis, and stenosis of the colon. Here, stenosis of the colon. We treated her with IP and systemic chemotherapy, and then gastrectomy with subtotal gastricorectomy. 11 years had passed, and she's still alive with no evidence of cancer, as you can see here. I will show you how we treated her. Before that, systemic chemo is the standard for gastric cancer with distant metastasis. These are recommendations in Japan, probably similar to the one in Korea. As Professor Bok mentioned, attraction for trial in East Asia showed the benefit of Nivo plus chemo in PFS, but not in OS. On the other hand, CheckMate trial performed mainly in the West showed the superiority of Nivo plus chemo both in PFS and OS. Based on the result of these trials, Nivo plus chemo is regarded as a standard in Japan, regardless of the site of metastasis. According to the subgroup analysis of these two trials, Nivo plus chemo seems effective for patients with CPS of 5 or more, and Nivo plus chemo seems effective only for patients with metastasis other than peritoneal metastasis. The hazard ratio is very low in patients without peritoneal metastasis. I think we should consider such a very strong interaction to select patients. So we need something different for peritoneal metastasis other than systemic treatment. IP, intraperitoneal chemotherapy using paclitaxel or docetaxel, and surgery after response chemo is very promising. We use taxanes for IP because of a high concentration, minimal systemic toxicity, and no adhesion. But the depth of drug infiltration into the tumor is limited, so IP should be repeated frequently for a long term with systemic chemo. Based on this constellation, we combine weekly IP paclitaxel with S1 paclitaxel. For IP paclitaxel, in a total of 1 liter of normal saline, it administered through a port simultaneously with IP chemo, usually in the outpatient setting. This is how we implant a port. It is important to suture and wrap the fascia around the catheter tightly to prevent the reflux of fluid from the peritoneal cavity. IP port-related complications such as infection and catheter obstruction are not very frequent and not very severe. I think this is very safe treatment. The pharmacokinetic study of regimen IV plus IP paclitaxel showed that this intraperitoneal concentration remained above this effective dose level for over 3 days. In the mouse model, we compared the distribution of paclitaxel in the peritoneal tumor after IP and IV infusion. After IP, paclitaxel labeled with fluorescent ring infiltrate the tumor in a very high concentration, like this. After IV, a small amount of paclitaxel can be detected around these red vessels in the tumor. So IV should be better than IV, and the combination of both is the best. This is the overview of our treatment. We implant a pod and repeat combination chemo weekly. When second-look laparoscopy reveals shrinkage or disappearance of peritoneal metastasis, we perform gastrectomy. We restart chemo as soon as possible, step by step, like this, and continue it for no less than 2 years, and taper it gradually thereafter. So surgery is just one step, huge step, but one step of the whole treatment. I will show the effects of IV chemo. These are findings before and after 6 months of IV chemotherapy. The nodules on the diaphragm and invasive metastasis in the parietal peritoneum and omental cake had shrunk after chemo, as you can see here. No, not so big. Without the video, it's just a picture. Yeah. Yeah, okay. And we have never seen response like this by only by systemic chemo. In the phase 2 study, the MSD was 23 months, despite that many of the patients had advanced P3 metastasis. Then we performed phase 3 Phoenix DC trial to compare this IP regimen with S1 cisplatin. Unfortunately, the primary analysis showed a p-value of 0.08 despite a hazard ratio of 0.72. But after additional follow-up for 1 year, like on the right side, the 3-year overage rate was 22% in IP and 6% in SP. We should have waited for 1 more year to perform the primary analysis. Today, I will give you more explanations regarding this trial. Many of the patients came to our hospitals to receive IP, and 6 of 50 patients in the SP group withdrew this trial and received IP elsewhere and lived longer, like this. When we exclude these 6 patients in the exploratory sensitivity analysis, the difference has come to be larger, and the p-value was 0.022. And the patient in the IP group had more ascites, which is shown here. There was a very crucial imbalance. When we adjust this imbalance, the hazard ratio was 0.95. Also, the primary endpoint was not met. The sensitivity analysis suggested the efficacy of the IP regimen, we believe. Now we have some other regimens combining systemic chemo with IP paclitaxel or docetaxel, like this. When we compare the studies of these 3 regimens, the patients in the Phoenix CC trial had more advanced metastasis and more ascites, so the results of these trials are not comparable. But the Phoenix regimen seems the best in OS, especially after 1 year. It's probably because of the safety of long-term safety of IV paclitaxel. It causes less neurotoxicity than oxaliplatin and less gastrointestinal toxicity than cisplatin. The number of causes was much more than the others. Median was 13 causes. Next, I will show the result of subset analysis of pooled data of these three trials, with 222 patients. By PCI, the patients with PCI of no less than 20 here had better survival, but no difference between these three groups. Even patients with PCI of no less than 20 lived as long as 20 months in median. I think it's much better than the previous reports of other treatment. By the amount of ascites, the patients without ascites had significantly better OS. MST was 20 months. In these trials, gastrectomy was recommended when marked shrinkage or disappearance of metastasis was observed. 42% of the patients underwent surgery after response chemo and had much better OS. I'm very glad to find that many doctors worldwide got interested in our treatment. These are the phase 1 studies of IP paclitaxel in Korea, Japan, and Australia. The recommended dose was determined to be 20 to 80 milligrams per square meter with no DLTs or common systemic adverse events. In the phase 2 studies, including the ones from Singapore and China, all the combination regimens tolerable. Frequent adverse events or common systemic toxicities may be caused by the systemic chemotherapy, and the IV port-related complications is not so frequent. The efficacy results were similar. 1 year OS was around 70 to 80. I cannot find which regimen. There are so many regimens. I don't know. I cannot find which is the best because the patient backgrounds are different. But based on the results of these trials, my personal opinions are any combination works well and safe. And high dose is not always necessary because the depth of drug infiltration into the tumor should be the limiting factor of this treatment. And weekly treatment should be better than bi-weekly or weekly treatment. Now, I'm the most interested in the DRAGON trial being performed by Dr. Zhu from Shanghai. They will get the result next year. When I met Dr. Zhu at IGCC this year, he seems very confident of the result. So I'm looking forward to the result. And next, Professor Hyun-Ho Kim has done a great job in IP chemotherapy. They combined bi-weekly IP paclitaxel with FOLFOX, a little bit modified FOLFOX. In the phase 1 studies, the recommended dose was determined to be 60 milligrams per square meter with DLT of febrile neutropenia. I'm very happy to find that in their phase 2 study, they got very promising data in OS and PFS. The MST was 17.5 months, and 1 year OS was 81%. We always have hot discussions both in Korea and Japan, and we collaborate to develop this treatment. Professor Johan Kim from Korea University and his PIPSTC study group performed clinical trials of SOX plus IP paclitaxel, similar to one of ours. The RD was 80 milligrams per square meter in their phase 1B trial. In the phase 2 trial, 1 year OS was 77%, similar to the ones of our trials. And now they are about to start the phase 3 trial to compare IP treatment with SOX. I heard that early in the next year, probably January or February, they will start patient enrollment. I'm always supporting him like this. This was 2 weeks ago, and like this, I hope they will succeed. And now we have 3 kinds of local treatment for gastric cancer. our way of IP using a boat, and HIPEC using hyperthermia, and the PIPAC with pressure. This treatment has been developed in Europe. When I compare these three treatments, PIPAC and PIPAC had advantage in the depth of drug infiltration thanks to heat or pressure. Our IP here has advantage in other factors. I think paclitax is one of the most effective drugs in monotherapy, and intraperitoneal concentration remained very high, and the treatment is repeated weekly for months or years. I think this is very important. Okay. IP can control peritoneal metastasis like this. This is what I wanted when I started IP chemotherapy 17 years ago. I wanted to find a way to perform surgery and cure this disease with my patients. The difference in response between peritoneal metastasis and primary tumor encourages us to perform gastrectomy. After confirmation of CY0 and no other distant metastasis, we perform second loop laparoscopy and proceed to gastrectomy when peritoneal metastasis well controlled. We perform gastrectomy when tumor is resectable by standard or extended gastrectomy, excluding PD thoracotomy or extended peritoneectomy. I will show the result of the retrospect study in P1 or CY1 patients treated with IP at our hospital in the first 10 years. Out of 158 patients, clinical response was observed in 98 patients, and the shrinkage or disappearance of metastasis was observed in 95 patients, and gastrectomy was performed in 94 patients, about 60% of all. Comparing the patients with and without surgery, naturally patients without surgery had worse OS and more advanced metastasis. So we cannot compare the result of both. Many patients received Phoenix regimen and some other regimens. The number of courses was determined considering the extent of metastasis before surgery, before chemotherapy, and response to chemo. The median was 6. Many of the patients underwent total gastrectomy, sometimes combined resection of spleen, colon, or the adnexus. D2 or D2 minus number 10 dissection was performed in many cases. Post-operative complications were acceptable, no grade 3 or higher after surgery. And 61 patients attained R0, and 44% in total had a histological effect of grade 1B or greater. Number of lymph node metastases are usually more than expected by preoperative evaluation. In a total of 42% of the patients had lymph node metastasis of N3A or B. The MSTV patients with or without surgery was 31 or 12 months respectively. Also, these are not comparable because of the difference in the background and response to chemo. The efficacy of surgery is strongly suggested by this huge difference. Next, I will show the result of subset analysis in patients with surgery. First, by the extent of peritoneal metastasis. P0CY1 or P1 patient could be cured in some cases. And even patients with P3 metastasis could survive more than 2 years. According to the residual tumor status, R0 patients had better OS, but even R2 patients lived as long as 2 years. I think this result supports our speculation that surgery which resulted in R1 or R2 is also effective when peritoneal metastasis controlled by chemotherapy, and chemotherapy is given after surgery as well. By histological response, patients with good response had better prognosis. And according to the pathological status, N3B patients have worse PS. So systemic chemo and lymph node dissection is also important, even in patients with peritoneal metastasis. The median PFS was 18 months. Recurrence was detected mainly in the peritoneum and occasionally in various organ sites. So systemic chemo is also very important. Now we are performing a phase 3 Phoenix CC2 trial to verify the superiority of combined IP and systemic chemo over systemic chemo for type of squamous gastric cancer. The primary endpoint is disease-free survival. The eligibility criteria are type 4, M0, P0, and macroscopic curative resection was performed in CY0 patients or seems possible in CY1 patients. This is the standard in Japan. Generally, CY0 patients are treated with gastrectomy followed by doublet chemo regimen. S1 docetaxel is more widely used. CY1 patients are treated either gastrectomy first or chemo first. We selected chemo first for the control group. The regimens are S1 oxaliplatin before surgery and S1 docetaxel after surgery. IP paclitaxel is added to the treatment of the control group. Two IP groups are collectively compared with two systemic groups in survival analysis. Of course, we wanted to make it simple, but we do not have sufficient patients to do so, unfortunately. And because of very slow accrual of patients, it will take several years to get the result. Finally, I'd like to introduce and acknowledge the members of a study group, now 42, all over Japan. We hope our treatment would be helpful for our patients, and on my behalf, this manga character, Keto character, states my conclusions. Here, we can do it, IP chemotherapy. Thank you for your attention.
The first one, now.
Thank you very much, and congratulations for hard work for IP therapy. I'm also, my institute is also involved in your clinical trial, but sometimes it is very difficult to differentiate whether the peritoneum metastasis or CY0 is completely or not. So sometimes after the first chemotherapy, induction chemotherapy, in a second look laparoscopy, it is very difficult to confirm whether peritoneum is completely off or not. So is there any other indicator or biomarker or something? What do you think about this, including a prospect?
Yes, thank you for your question, and thank you for your help always. And thank you for the very good question. I think complete response is very difficult to attain, probably almost impossible. And when we found almost no metastasis after second look laparoscopy like this, some cancer cells should remain somewhere on the peritoneum or in other organs. So I think that it is not necessary to confirm complete response, but I think comparison is very important. Marked shrinkage is good enough to consider surgery for this patient because we continue chemotherapy after surgery as well, like this. So of course, R0, real R0 is very good for us, but even R1 or R2, we can continue treatment, and we do continue treatment. And least at that time, the treatment is effective. And in many cases, we can control the remaining peritoneal metastasis after the surgery for years.
Okay, this is also one of the conversion concepts.
Yeah,
Okay.
a little bit extended
Yes,
concept of
yeah,
conversion.
okay.
Yeah.
Thank you very much.
Thank you.
And thank you very much. Thank you so much, Professor Ishigami. So I really appreciate your continuous effort and your enthusiasm. Yeah. So I now see some progress today. So I'm very happy to see that. And then starting a new trial very successfully for the adjuvant trial now. So my question is, so you show the kind of survival, the median survival is yours in the data, or so even in the entry patients and some very advanced cases, those survival, I mean, the time is much longer than any stage 4 peritoneal metastasis cases, I think. So it's more than 1 year, at least more than 1 year, or some more than 20 months. So what is the reason? I'm somewhat curious, if there is a kind of selection of the patients in your data, and then maybe is there any kind of indication for this kind of IP chemotherapy in your patient selection? That's my first question.
Yeah. Thank you for your question, and thank you for your support always. We have no good biomarker or something to select patients. At this moment, we enroll any patients with peritoneal metastasis without other distant metastasis. And actually, we do not know before treatment whether this treatment is good for this patient or not. Even after a lot experience of a lot of patients, we still do not know this treatment is good or not for this patient. So at this moment, we treat patients with peritoneal metastasis and without other metastasis. And probably we need some good biomarker or something to select patients.
So maybe, if the patient's general condition, maybe performance is not good, and then if the patient cannot eat normally the food, well, do you also include that patients to your kind of treatment?
Yes, it depends on the performance status of the patient. As for the clinical trials, we enroll patients of PFS of 0 or 1, 2. In practice, we treat patients, even patients with PS2, with inadequate oral intake. In such cases, we use FOLFOX plus paclitaxel, similar to the ones at Seoul Bunda Hospital.
Okay.
Yeah.
And then you didn't. You told us that there is no biomarkers.
Yeah,
But you have done a lot of kind of trials and then patients' experience.
And
do you have some plan to do some kind of translational research?
We
Or
have-
you already done? You have done those translational
we
research?
have them, but not found a good biomarker.
You have done, but you couldn't find any.
My colleagues have done a lot of job regarding the biomarker, so regarding this treatment, but no good biomarker.
Yeah. Okay. Thank you very much.
Thank you very much.
Do you have any experience of the difference of the histology in terms of response? So I mean the signal training, fully differentiated, or some case of 2-2, so moderately differentiated tubular cancer may have peritoneal seeding.
Yes, thank you for your question. Actually, I omitted that slide today, but in this 222 patients, we analyzed by their histological type, but no difference at all. Yeah, even signaling cell, 2-1, 2-2 are very similar survival curve.
I'm Hong Man-young from National Cancer Center, Korea. Thank you for a wonderful lecture. I have a simple question for the indication of the Phoenix GC trial. If the patient has no patient sitting in the city, but when we do the diagnostic laparoscopy, we find some the patient sitting nodule. That patient is also included in your trial.
Yeah, we diagnose with laparoscopy, not by CT or some other diagnostic imagings.
Yes. If the patient, when do you perform the diagnostic laparoscopy, second look diagnostic laparoscopy, and how do you evaluate the patient?
Yes, as I shown here, we started with IV combination chemo, and at some point we performed second look laparoscopy. It depends on the extent of peritoneal metastasis before treatment here, and the response can be evaluated by CT or some other imagings. So when patients have limited metastasis, we perform second look around 3 months or so. And when patients have advanced metastasis, we wait 6 months or more. And depending on the findings obtained by a CT or some other diagnostic image. And we can use peritoneal Mossing cytology using a pouch. And it's very important as well.
Thank you.
Can I ask your personal opinion about high pressure?
PIPAC? Yeah, PIPAC. I think PIPAC may be effective and very good results. Some of the European doctors showed. And actually, Professor Hyun-ho Kim started in Korea, just one case. And that was amazing. So now I believe in PIPAC, but what is not very good regarding PIPAC is that it needs a general anesthesia and it cannot be repeated many times, only twice or 3 times at the interval of 6 weeks or more. So combination of PIPAC with our POTYP should be the best. So I think I want to start PIPAC in Japan, but as you know, it's very difficult to start something new in Japan.
Thank you very much.
Thank you.
Great. The next speaker is Professor Naki. And I will talk about the current status of minimally invasive surgery for gastric cancer in Japan, probably including robotic surgery as well.
Thank you very much, Professor Sasako, for kind introduction. And also, I appreciate Professor Hyun-ho Kim for honoring invite here. My topic is the current situation of minimally invasive surgery, MIS, for gastric cancer in Japan. But I refer to Japanese evidence comparing to Asian other countries' trials. So in the 6th edition of the gastric cancer treatment guideline, clinical question 1, is laparoscopic surgery recommended for clinical stage 1 gastric cancer? For this clinical question, distal gastrectomy was strongly recommended as a standard treatment option. Total gastrectomy and proximal gastrectomy were weakly recommended, but new comments will come later on according to new evidence. According to the questionnaire survey of the Japan Society for Endoscopic Surgery, the number of laparoscopic surgeries has increased rapidly since the early millennium, and since 2018, the number of robotic surgeries has also increased. Laparoscopic surgery for gastric cancer has been tested in multi-center prospective randomized controlled trials in Asian 3 countries, where the incidence of gastric cancer is high, and they are summarized in the table below. The 3 countries have conducted clinical trials: distal gastrectomy, total gastrectomy, early cancer, and advanced cancer at the same time, with different timings based on their own study designs. Today, we will review each study based on the paper presentation of their RCTs. First validation study of laparoscopic distal gastrectomy for early gastric cancer was reviewed. The JCOG 0912 study and the KLAS 01 study were conducted in Japan and South Korea, where the detection rate of early gastric cancer is high. The results of JCOB 0912 study and KLAS 01 study, including long-term results, have already been verified and published in The Lancet Gastroenterology, Hepatology, and JAMA Oncology, respectively. The JCOG 0912 study is randomized controlled trial study to verify non-inferiority of laparoscopic distal gastrectomy to open distal gastrectomy for clinical stage 1 gastric cancer, targeting clinical stage 1A and clinical stage 1B. The primary endpoint was recurrence-free survival in patients with T1N1, T2, and 0 gastric cancer. The surgical results are published in the journal Gastric Cancer. The total number of patients enrolled was 900 over, with 400 and 400 patients in the laparotomy and laparoscopic group. And comparative verification was conducted. The surgical results showed that the median operative time was significantly longer in the lap group, and 278 minutes compared to 194 minutes in the laparotomy group. And the amount of blood loss was significantly lower in the lap group at 38 millimeter compared to 100 over milliliter in laparoscopic group. There were no differences between 2 groups in other items. Regarding short-term clinical results, the median time for first flights after surgery was 3 days in the lap group and 2 days in the laparoscopic open group, and 3 days, and 2 days in laparoscopic group, which was significantly faster, and the proportion of patients who used analgesics on days 5 to 10 after surgery was significantly lower in the laparoscopic group compared to open surgery. Regarding adverse effects, the elevation of liver enzyme was significantly higher in the laparoscopic group compared to open surgery, but there are no differences in other adverse events. In conclusion, LDG was confirmed to be as safe as ODG in terms of adverse events and short-term clinical results. Long-term survival results from JCOB 0912 trial were published in Lancet Gastroenterology, Hepatology. The 5-year recurrence-free survival rate was 94% in the laparotomy group and 95% in the laparoscopic group. The hazard ratio was 0.84, and these results demonstrated the non-inferiority of LDG to ODG in terms of 5-year recurrence-free survival. The 5-year overall survival rate was 97% in the laparoscopic group compared to 95.2% in open group. The hazard ratio was 0.83. The most common grade 3 or 4 adverse event was intestinal obstruction, occurring in 2% of patients in the open group and 1% in the laparoscopic group. Additionally, there was no treatment-related deaths. In a subgroup analysis of recurrence-free survival, patients with BMI of 25 or higher tended to have a lower survival rate in the LDG group than in the ODG group, but the difference was not significant. The KRAS-01 study targeted the same study group as the JACOB 0912 study, and the primary endpoint was overall survival. In KRAS-01, as a result, in the analysis of the ITT group, there were no significant differences between the two groups regarding cause of death or recurrence. The overall survival rate was 94% in the laparoscopic group and 93% in open group. Hazard ratio of 0.93, which was comparable between two groups. Cancer-specific rate were 97% in the laparoscopic group and 97% in the laparotomy group. Hazard ratio 0.91, which was comparable between the two groups too. In conclusion, complications and long-term oncological outcome of LDG were comparable to ODG in clinical stage 1. Okay, as a pose, I will demonstrate laparoscopic distal gastrectomy, D1 dissection, and B1 delta reconstruction for early gastric cancer. So movie was a little bit long, so I will skip. This is a number 6 lymph node lymphadenectomy. And also this is a suprapancreatic lymphadenectomy. We respect the concept of outermost layer. Keep this layer, we can completely safe and curative lymphadenectomy like this. This procedure is almost standardized in all over in Japan. And B1 construction, we choose delta anastomosis method like this. Okay, next is a validation study of laparoscopic total gastrectomy for early gastric cancer. For this subject, the JACOB 1401 study, KRAS-03 study, and CRAS-02 study were conducted in each country. The result of the JACOB 1401, KRAS-03, and CRAS-02 studies, including long-term results, have already been verified and published in Gastric Cancer and JAMS Oncology. The JACOB 1401 study is non-randomized confirmatory study on the safety of laparoscopic total gastrectomy and laparoscopic cardiac gastrectomy, proximal gastrectomy for clinical stage 1 gastric cancer, targeting the same clinical stage 1 gastric cancer patient as the JACOB 0912 study. The primary endpoint is jejunal anastomosis. The second is a recurrence-free survival period. The third is rate of complication of laparoscopic surgery and rate of transition to open surgery and adverse event rates and so on. The study had a total enrollment of 2,100 over patients. Total gastrectomy case accounted for approximately 80%, and the remaining 20% were proximal gastrectomy cases. In terms of short-term results, postoperative exhaust gas was confirmed on third day. Painkillers were used in 48% from the 5th to 10th postoperative day, and the fever within 3 days after the surgery was 37.8 degrees or less. There were no surgery-related deaths. The instance of grade 2 to 4 esophageal jejunal anastomotic failure was 2.5%, and there were no anastomotic structure. Grade 3 to 4 adverse events were 29% overall, with rate of intra-abdominal abscess and pancreatic fissure being 3.7% and 2.2% respectively. The results demonstrated the safety of laparoscopic total gastrectomy and laparoscopic proximal gastrectomy for clinical stage 1 gastric cancer. Similar to JCOG 1401 study, the KRAS-03 study is a non-randomized confirmatory study on the safety of laparoscopic total gastrectomy and proximal gastrectomy for clinical stage 1 cancer. The results demonstrated the safety of laparoscopic total gastrectomy and proximal gastrectomy as a Japanese trial. The KRAS-02 study is prospective randomized controlled trial rather than the Japanese and Korean single-arm validation study. The results conducted that experienced surgeon can safely perform laparoscopic total gastrectomy with lymph node dissection for clinical stage 1 gastric cancer. Now I will show you the esophageal jejunal anastomosis with overlap method. A small hole is made in the dorsal stump, which is transected dorsally and ventrally direction. The insertion hole is closed with one layer continuous suture using a barbed suture like this. Make sure to move the hands so that the mucosal membrane don't evert. So suturing is very key in this anastomosis. The leakage check is complete. So the next is validation study of laparoscopic distal gastrectomy for advanced gastric cancer. For this subject, the JLSSG0901, KRAS-02, and CRAS-01 studies were conducted from Japan, South Korea, and China. Next is validation study of laparoscopic distal gastrectomy for advanced gastric cancer. This is the same slide. So the JLSSG0901 study is a randomized phase 2-3 study on the safety and curability of laparoscopic versus open surgery for advanced gastric cancer. The target is clinical diagnosis T2 for N02, M0 cases, excluding bulky N2. The primary endpoints were the incidence of pancreatic fissure and anastomotic leakage in phase 2 trial and RFS in phase 3 trial. This is the result of the phase 2 trial. Of the total enrollment, 180 patients, 89 randomized to ODG to 91 to the LDG group. The LDG group was analyzed. Leakage rate was 1.2% and the pancreatic fissure was 0, demonstrating the technical safety of LDG with D2 lymphadenectomy for locally advanced gastric cancer. A total of 507 patients were enrolled in the phase 3 from 37 institutes nationwide, with 252 patients assigned to the LDG and 255 patients assigned to ODG. In terms of short-term results, the LDG group had significantly less blood loss and significantly shorter time to first day of flatus and a significantly longer operation time compared to open surgery. There were no significant difference in postoperative analgesic use, intracorporeal and postoperative complication, or in hospital mortality. In conclusion, with D2 lymph node dissection for locally advanced gastric cancer can be safely performed by qualified surgeon. In early this year, the long-term result was clarified and non-inferiority of LDG was clarified. The primary endpoint was 5-year RFS and the hazard ratio was set at 1.31. The secondary endpoint were 5-year OS. In this study, LDG with D2 lymph node dissection for locally advanced gastric cancer, when performed by qualified surgeon, was proved non-inferior to ODG. The median follow-up for patients after randomized was 67.9 months. In the first analysis, the 5-year RFS was 73% in the ODG group and 75.7% in the LDG group, respectively. The hazard ratio for RFS in the LDG versus ODG groups was 0.96. The 5-year OS was 79.8% and 81.7% in ODG and LDG, respectively. The hazard ratio for 5-year OS in the LDG versus ODG group was 0.83. In the PPS analysis, the 5-year RS was 78.4% in the ODG group and 81.4% in the LDG group. Hazard ratio for RFS in the LDG was 0.9, and the 5-year OS was 83.6%, and the ODG group 86.6%. Hazard ratio of 5-year OS in the LDG was 0.75. After curative resection, 46 of 254 patients, which is 18.1%, and 44 of 200 over patient, which is 17.7% in ODG and LDG group showed recurrence, respectively. The recurrence pattern was similar between two groups. So today, the Gastric Cancer Society published a bulletin on its website stating that laparoscopic surgery is one of the standard treatment for clinical stage 2-3 gastric cancer. KRAS-02 was also conducted in the same target group as the SSG-0901 study with a 3-year recurrence-free survival as primary endpoint. As for surgical results, no difference were observed in other surgical outcomes except operation time, blood loss, and reconstruction. There was no significant difference in the 3-year RFS between two groups. In conclusion, it was stated that laparoscopic gastrectomy with D2 dissection is supported as a standard treatment for locally advanced gastric cancer when performed by qualified surgeon. The CRAS-01 study is multi-institutional prospective randomized control study, similar to Japan and Korea study. There was no significant difference in 5-year OS by stage between LDG and ODG. In conclusion, it was stated that there was no significant difference in 5-year OS of locally advanced gastric cancer who underwent LDG and ODG with D2 dissection by experienced surgeon at high-volume specialized center. I will show you D2 lymph node dissection in a relative obese patient. This is a suprapancreatic lesion. This is also, I will skip. 11P dissection is an important key, and 12A is also important for D2 dissection. The same concept, I will perform the D2 dissection too. And another 11P dissection is performed like this. So finally, this is a validation study of laparoscopic total gastrectomy for advanced gastric cancer. For this subject, SHIRAS-04 study is being conducted in China, and JACOB 1809 study is being conducted in Japan. The JACOB 1809 study is a phase 2 study on the safety of laparoscopic spleen sparing, preserving splenic hilum dissection for advanced upper gastric cancer that invades a greater curvature and is currently enrolling. The SHIRAS-04 study is a prospective study that evaluated safety, and this is already published. Regarding upper gastric cancer, paper from JACOB 0110 trial, the spleen should be preserved in advanced gastric cancer that doesn't involve the greater curvature. However, splenectomy is still recommended for advanced gastric cancer in the upper part body that invades the greater curvature. The aim of regarding upper gastric cancer, paper from the the aim of this study is to confirm the safety of laparoscopic or robotic assisted total gastrectomy with spleen preserving splenic hilum dissection for advanced gastric cancer in the upper part of stomach tumor, MP2SE, macroscopically invading the greater curvature. Primary endpoint is incidence of pancreatic fissure and or intra-abdominal abscess. The number of recruiting patients is 85 and registration is currently underway or almost finished. On the other hand, the SHIRAS-04 trial has already been completed as a single-arm prospective multi-institutional study to verify the safety of spleen-preserving number 10 lymph node dissection. The primary outcomes were postoperative complications. The overall complication rate was 13.6% with many intra-abdominal and respiratory infections. In conclusion, it is demonstrated that laparoscopic spleen preserving total gastrectomy is a safe and feasible surgery for upper advanced gastric cancer when performed by an experienced surgeon. So finally, we've demonstrated the dissection around the splenic artery during laparoscopic total gastrectomy. So this area I will skip. So this is also suprapancreatis lymphadenectomy. And this is a lymphadenectomy around the distal part of splenic artery. So this is a frontal side of spleen and hilar. This is a standard, not advanced, but a standard splenic hilar dissection. So to summarize the evidence of laparoscopic surgery, this is one of the standard treatment options for clinical stage 1 to 3 gastric cancer. The safety of laparoscopic spleen preserving total gastrectomy for upper advanced gastric cancer was confirmed by SHIRAS-04, but JACOB 1809 confirmed the safety of laparoscopic spleen preserving splenic hilar dissection for upper gastric cancer invading greater curvature. Phase 2 trials are currently underway. Finally, the present, and then I would like to mention future challenges. There are 3 issues like this: robotic surgery, MIS for neoadjuvant chemotherapy, and third is MIS for conversion surgery. This is a table of current status of insurance coverage for robotic surgery in Japan. since 2018, general surgery procedure has covered by health insurance system in Japan like this. And so this is a ratio of robotic surgery in recent years. Almost 20% of MIS performed by robotic surgery. And now JCOC 1907 study is currently conducting a randomized control trial to verify the superiority of robotic assisted gastrectomy over laparoscopic gastrectomy for clinical T1 to 4A and N023 gastric cancer, which is called JCOC Mona Lisa study. This is a video of robotic surgery around suprapancreatic lymphadenectomy. As you can see, we can use articulated forceps in robotic surgery and 3D stable visualization. So maybe superiority to laparoscopic surgery will be demonstrated by this Mona Lisa study. I will also expect it so. So regarding MIS after neoadjuvant chemotherapy, the issue is fibrosis and edema. So we can't find in that difficult cases the clear and dissectable layer, even if we make a good traction as in a standardized procedure. So maybe a complication, intraoperative or postoperative complication will or maybe occur in that in these difficult cases. So the result of Combo GC1 and International Match Center retrospective study demonstrated that the MST for cases in which R0 rejection was performed was 44 to 116 months, which was very good treatment outcome. We have recently performed convergent surgery on many cases with relatively good results. And we will verify the accumulated data in the future. This case is performed para-aortic lymph node dissection. Before chemotherapy, the metastasis of number 16B1 lymph node. And after effective chemotherapy, we perform this lymph node dissection like this. Maybe this procedure is very difficult to do by laparoscopic surgery. Maybe robotic surgery facilitated this, such a procedure like this. So we believe that multidisciplinary treatment is also important for gastric cancer. We call the concept of bringing MIS into convergent surgery mix. So minimally invasive convergent surgery. So this is the last slide. MIS for gastric cancer is recognized as one of the standard treatments, and the scope of surgical treatment for gastric cancer has shifted to advanced cancer. Due to advances in drug treatment, it is necessary to respond to NAC surgery after NAC surgery and convergent surgery. Technologies such as laparoscopy and robots have the potential to realize more precise and less invasive tumor cures. Thank you very much for your kind attention.
Now this paper is open for discussion. You mentioned about the difficulty of finding out the outermost layer after chemotherapy. In that case, which layer you go?
Yes.
You take out all the nerves surrounding the artery?
Yes. First choice is I think remove nerve. Yes. Yes. But it is a very attention to injure the splenic artery or common hepatic artery. Yes.
Do you find some difference between the surgery after 2-3 courses of neoadjuvant and long-term chemotherapy in convergent surgery?
Actually, I don't detail difference, but maybe long chemotherapy made it more fibrosis. I think so.
But even 2 courses or 3 courses for 2-3 months of chemotherapy, that causes fibrosis?
Yes, but maybe edema is mixed. Fibrosis and edema mixture is found, but long-term chemotherapy, maybe the ratio of hard and yes.
Thank you very much. Yeah, was Inaki, very nice summary about the clinical trials performed in the 3 countries, Japan, Korea, and China. But it's not the critics for your presentation, but actually the overall critics for the studies we have done for 3 countries. So this is my critics. So I just love to hear your opinion about my critics about the 3. The one is all those studies performed, it's a randomized trial, so enrolling maybe around 1,000 patients. But the design-wise, their non-inferiority trial is somewhat failed to meet kind of scientific criteria because the hazard ratio was somewhat so high. And then even the non-inferiority margin was not met, but the conclusion is non-inferiority was met. So that's my critics. And then second thing is, so although the study, the enrolled patients is inclusion criteria, so somewhat very severe cases like a conglomerated nodes or N3, those kind of stages 3B or 3C disease was almost, selected out in the, I think, Chinese and then the Korean, maybe even in Japan, because, the survival rate in advanced cancer trial, the Japanese trial is over 85%, so high. So if you know that, survival rate in stage 3C is not so high, right? So when you see the results, we have to conclude that, those included patients have a somewhat less severe disease. So it's not representing all advanced cancer cases, but every guidelines in Korea or Japan, even, I don't know about China, but they, stated, so rapidly, announced that, the guideline that we accept laparoscopic surgery for the advanced cancer, even including the stage 3. There is no other comments. But in the study, actually, they concluded that just by experienced surgeon, it's a non-inferior or it's a comparable result. So as I experienced a lot of cases of laparoscopic surgery, now I don't do laparoscopic surgery for the stage 3. So my indication is up to stage 2. So I'd love to hear your opinion. Is it right or wrong?
Very difficult question, but one is yes, guideline is made by RCT, by selected institute, selected surgeon, selected medical oncologist. So this is a little bit paradoxical for real world clinical patient. So this is a struggle or dilemma of our surgeon or scientist. The second point is real advanced gastric cancer by MIS. I believe now, contrast with you, I believe the minimally invasive procedure is maybe contribute to the therapeutic dose, something like this. So we have to find a way to confirm and demonstrate this mechanism of like this.
Yeah, that's a very good hypothesis. So we need to do a very well designed clinical study to evaluate that. I'm just telling that, when we do something, so with this instrument, it's a laparoscopic surgery, it's just technical thing. Actually, the surgical extent or surgical kind of way or those kind of principles not anymore changing. So basically, if the surgeon think it's radical surgery for the patient, they already surgeon set the goals. So it must be same result. So I think regardless of any technology, I think the survival rate must be same. But of course, there's a limitation. But if some surgeons have some kind of limitation during the surgery, he must stop and then convert to what they can do, right?
Yes.
So I think this kind of trial anymore, like a randomized trial is not needed because, we have already more than 20, 30 years of experience with this kind of minimal invasive surgery. Everything can be done, but that we need to focus on more important thing maybe. That's my idea. So in our society, our surgical society, I think we have some rational idea that those kind of needless clinical trial, as Professor Sasako suggested in his presentation, and we need to think, is it really beneficial to the patient or something? Because the patient resource is very, very valuable resource. So we need to focus on more important clinical trials. And then we need to minimize the trial to see some kind of feasibility. There's maybe 100 patients or around 100%, those kind of patients. I think it's needed is a clinical study is quite important, but those kind of, what we have done for 20 years, of course, it's very valuable, I agree, but not anymore in the future. I mean that. And then we need to, it's very important to see very critical kind of view for our studies, not just a kind of, I mean the kind of, some so satisfied with the result, but we need to be more humble to see our result, and then we need to review cautiously, what is the limitation of our studies. Those kind of things is needed for our society. That's what I mean. Yeah.
Thank you for good suggestion. Yeah, thank you.
Professor Kim mentioned each 3 studies had some problem. And China's ELAS-1 is for advanced humans. And in that study, many of patients got involved in the study who the researchers knew that follow-up was impossible. And some patients would not themselves give informed consent. How do they have informed consent? That's the reality in China. And the KRAS-2, some selection of patients were done. If the patients were allotted to the laparoscopic surgery and it was very advanced tumor, then the surgeon decided to carry out the open surgery. So there's some patient desire or doctors feeling this perform some different treatment. And also their analysis, the final one at crossover included. So there are several critics. And also Professor Eto himself told us that he's very careful because that trial was only for distal gastric, excluding United Plastica or big tumor. So we cannot apply that result to every stage. No, we should be very careful. Thank you very much. Okay. Now the last speaker. What I know is
Thank you very much indeed. Keeping, but until the final kind of presentations. It's a year end. Many people went holidays, but I'm so sorry. Keep you, in this auditorium for the very serious topics, but very important topics anyway. Why? 아직도 이걸. Yeah, I sent a mail, but it's opening. Okay, my talk today is on the somewhat straight, maybe somewhat looking weird topic. I have never talked before, somewhat including a lot of kind of just an idea, prospective kind of idea is just somewhat maybe just an idea, philosophical idea. So you can just enjoy, sit back and enjoy, and then you can think another way. But actually, I was in the past. I was a president at the SMIT in 2018. The SMIT is a Society of Medical Innovation and Technology. At that time, I have kind of event, have a kind of ethical medical innovation technology kind of declaration. It's called the Seoul Declaration for the Ethical Medical Innovation. So that was kind of good motivation for me. Okay, yeah, all right, okay, yeah. So that was a kind of motivation for me to have an interest for the AI. So it's a kind of 5 years, to have an interest for the AI. But during those 5 years, the AI became a huge issue. I have never expected at the time. So now we have a kind of, just around the corner, the whole healthcare can be transformed into AI. Maybe we could expect. So what we need to do is thinking over the application of AI in the gastric cancer surgery, because I'm a surgeon. So this is a perspective by gastric cancer surgeons, but just enjoy. No conflict of interest. Yes, innovation is essential for achieving better patient outcomes in gastric cancer surgery. So, the MIS was a revolutionary concept in terms of patient-centered idea, not just the technology, but it's actually patient's pain was a primary kind of concerns. It's a very revolutionary. That thing is just a revolutionary idea, I think. But the most important kind of thing we could consider is utilizing advanced technology. So surgical innovations expanded treatment options, allowing for tailored approaches actually. So I will explain later. And then innovations such as image-guided surgery or precision technologies will help reduce complications and improve patient outcome and enhance their quality of life. And that must be our goal. So when you think of the history of MIS, it actually began in the 19th century. So the first endoscopy was developed in 1912, but at the time, the surgeon can see with his own eye to the scope. And then it means that he needs to control one hand, the scope by himself, because nobody can see, so they cannot control. So surgeon can use only one hand. So the surgery must be very, very limited. But actually, real revolution was we could use kind of digital visualization after the inventing the CCD, charge coupled device, to make the visual signal into the electronic signal. That then made this kind of surgery is possible because the vision inside of the abdomen can be transferred all over the world actually with the online, with the network. So it's a totally changed this kind of paradigm of the surgery. And then this very rapidly, many people applied this, and then Professor Gitano, for the first time, he performed the laparoscopic gastrectomy. And then now the robotic surgery also started, all from Japan, actually. So very impressive. And then enhancing the gastric cancer surgery is meaning the intersection of technology and patient care. We could tell that the surgeons leverage extensive patient data from advanced diagnostics and genomic profiling to inform gastric cancer surgery. Hopefully, we are somewhat early to talk about the genomic profiling for the surgery, but maybe we are now doing more and more research for that biological information for the cancer. And then for cancer is quite difficult, but now in the US and then Korea and then Taiwan or Japan, in the China, there are, at least those countries are now doing some proteogenomic studies continuously, and I think maybe within 5 years, maybe we could have so much more, better knowledge and information for the gastric cancer biology, and then we can apply those concepts to the surgery, I think. And the minimally invasive options such as image-guided and function preserving and the robotic surgeries broaden the scope of treatments, for 20, 30 years. And continuous education in new surgical technology is essential, actually, not only just for the kind of guidelines. The real important thing is to train education, for the surgeons who can perform the surgery and then apply the idea of minimally invasive surgery to their practices, to open surgery to the minimally invasive. Yeah, it's important. And AI tools are crucial for analyzing clinical data, enhancing decision making and surgical outcomes. But it could be kind of a conclusion of this talk, but I will tell later. Yes, this is my story. I have published this in 2004, very long time ago, about the hand-assisted laparoscopic distal gastrectomy. And then I have done the hand-assisted laparoscopic total gastrectomy. I found that it was a kind of first report to do a laparoscopic total gastrectomy with hand-assisted, but just a case report. But I was very interested in those kind of using very technologies, kind of minimally invasive surgery concept for the patient. And then I was interested in doing clinical trials. When I moved to the National Cancer Center, and I have organized a clinical trial group with a COACT. So COACT 1001 means a year, like a JCOC trial is 10 is the year 2010 is the first trial in the 2010. So it was trial for the advanced cancer, and then I have our group published it to the Annals of Surgery in 2018. But this study actually warned to apply laparoscopic surgery for advanced cancer, even in the stage 3 cases. Yeah. And then addicted trial, we finished the enrollment. It's about the surgical extent. Somewhat earlier advanced cancers, we can optimize surgical extent to the D1 plus, not rather than doing aggressive D2 gastrectomy. And then I have done also Aaron trial for the robotic surgery feasibility. And then we found some kind of possibility in the stage 3 robot can be useful, like Professor Inaki suggested. I have done also for this study. And then recently I have devised the kind of new reconstruction for the after proximal gastrectomy. It's called the spade operation, looks like a spade shape, with a shape after the reconstruction. And then I found it is very helpful to reduce the reflux after proximal gastrectomy. So we are now preparing for the clinical trial. It's a phase 2 trial, so just maybe 150 patients we are designing now. And then for the middle segmental gastrectomy, the terminology was maybe first time I used for the middle segmental gastrectomy, because the selecting the patient important for this middle segmental gastrectomy. We didn't publish yet, but result, the outcome was so good that we are also preparing for the clinical trial to do some middle segmental gastrectomy for the very selected indications. And then our colleague, Japanese colleague, Kitagawa, Professor Kitagawa from Gayo, is leading the concept of the sentinel of the navigation surgery and published the JCO already 10 years ago. But final day in Korea, my colleague, Dr. Ryu, Dr. Gunnar Ryu, has performed the Senorita trial to show that the feasibility of this concept for the early cancer. And then my colleague, the head of our Center for Gastric Cancer, Dr. Chang-Gyu Kim, has done the NEST EFTR. It's a non-exposure technique. It's somewhat very similar with the LAX developed by Japanese surgeon or news, but it's a non-exposure simple suturing, and then endoscopic full thickness resection has a lot of benefits. So somewhat almost similar with those kind of trials by the Japanese, I think. But anyway, we are doing a clinical trial. It's important, I think. So anyway, this kind of optimizing the surgical extent and then improving the quality of life is a very important issue. And then I'm telling that we are developing very new kind of optimizing the surgical extent and function preserving surgery. All those kind of selections are now very much more diverse, comparing with 20 years ago. So now maybe it's time to apply those kind of tools. When you see some patients, what kind of treatment is optimal for this patient? But it's somewhat difficult, right? So some surgeons just depend on his experience or knowledge, but maybe for the patient, and maybe we need to develop something, to help the right decision for the treatment for the specific patients. So this is a kind of concept suggested in the last year. Then a non-exhaustive map of the AI in the healthcare applications. They suggested from the basic biomedical researches to translational research, and then clinical practice, like diagnosis, patient satisfaction, and surgical procedure planning, like this. So it's included in the AI healthcare application they have suggested. So that it means that it's just around the corner of applying this concept in the clinics. And then already, it's a more fascinating things of the autonomous robotic surgery was developed already in the Johns Hopkins, has done for the kind of animal study. They showed even better outcome to doing an autonomous surgical procedure than the human being. So, we should expect, this autonomous surgery, not all surgical procedures, but even some specified simple procedure we can make the robot do, and then it could be better than the human surgeons, because they, the robot can have some benefit because in a very small field, like magnifying the view, and then kind of a suturing, without any tremor or those kind of thing can be done by machine easily, right? So we can expect this kind of thing within, I think, 10 years. And then endoscopic robots, maybe if we develop some endoscopic robot, all those kind of endoscopic procedure now is ongoing in the clinical practice, is totally changed. And then this kind of robotic endoscopy, this is a Korean company, Endomaster, that they already showed some kind of ability to making this robotic endoscopic procedure. And in Hong Kong, in the Philip Chu already finished the clinical trial We are using their developed endoscopic robot, but in Korea also we are developing. And then this kind of imaging and virtual reality or augmented reality, makes the surgery, so if the surgeons were supported by this anatomic guideline, by the VR or AR, and then this kind of pre-operative designing with bioengineering and then bioprinting. And finally, big data. And as I said, if we have a lot of information from a patient, we can utilize them to choose proper, the accurate diagnosis and proper treatment. We can decide, not just by her own kind of experience, but incorporating whole kind of world's expert data. If it is combined, and then if it make a kind of vast kind of decision making, that must be beneficial for the patient, I think. So this kind of thing we can expect and then imagine. So future gastric cancer surgery that is done of AI and technological integration. We can do many things from the education and training and preoperative support and diagnosis, and then intraoperative decision making, and the real, operative procedures, and then post-operative care, and then kind of surgical quality evaluation, and then doing those kinds of things. And then, so integration of the multimodal data means that not only those kind of literature data, the kind of visualization data like pathology or radiology data, not a radiological finding or pathological finding, but the radiological data itself, because computer vision can take the kind of visual data directly from a radiologic image or pathologic images. All those kind of thing, and also omics data, proteogenomic data from the cancer tissue can be integrated, and then that can help to augment surgical decision making. So all the phases of treatment. So what is the future of gastric cancer surgery? I think it must be tailored surgery with a molecular precision medicine and AI decision support. In the US this year, they have announced in the ARPA-H project, their second topic is a precision surgery. So I think mainstay idea of the precision surgery is using those kind of not only just omics data and then every live log data or clinical data, all should be integrated to decide right kind of diagnosis and right decision making for the surgery, and then even performing the surgery so very accurately, not to make the kind of reoperation possibility, and then improve the surgical quality and outcome. Yeah, so we have those kind of data, and then already newly developed many options. So, but people don't know what is better for the patient. But maybe AI, we could utilize the AI those based on those data. And computer vision, people are very much interested. Like the Monica Ortiz from Italy is very interested for the computer vision. Of course, it's important, for surgical quality assessment in the very initial stage, but eventually it could be used in the autonomous surgery, I think, is the future. And then generative AI, so we can predict the treatment response and optimize the surgical selection and improve the patient outcome. We can expect. And then those kind of concepts already suggested and published in Annals of Surgery in 2018. It's amazing, right? And then multimodal, what is multimodal? I already explained. Multimodal is not only using text or audio or image, bioinformatics. This model is you use those kind of multimodal. It's not multimodality, but it's multimodal. So you should accustomed to this concept. It's a multimodal. But actually, you must have heard about the ChatGPT, right? ChatGPT 4.0 was, already in the market. I'm using a ChatGPT 4.0. I bought, but the ChatGPT is a large language model, right? But it's just a language model. But this is somewhat different or same actually, because the basic algorithm is similar with those kind of large language model and this multimodal. Actually, like this kind of concept is a model, it's kind of multimodal machine learning neural network. It's a convolutional neural network. It's like an imaginary idea, to I mean the copy of the system in the brain. So like on neural cells, a neuron and over this kind of synapses, this is just exact kind of a imitation of this brain like an function in the computation. It's a computational model, but just a copy of that brain. So what is difference then between this traditional programming versus machine learning? The traditional programming, so if we have a rule and data, if there is a data is input, there is a just corresponding answer is outcome, right? But the machine learning is totally different. So if we have some data and then something is done, every time we use that with the machine learning, we just make rules, have different rules made by the, because the feedback by data is rules are made again and again, and that rule is invented by this machine learning. It's a very different idea. So what's the problem? So we have a very bright future, right? But maybe like a moon in the dark side, the other side of the moon is very cold, the another world. It means that there is a pros and cons. So my concern was using this kind of AI before we talking about the ethics issue is very, very harmful. It could be very harmful for the patient. So of course, we need to promote human well-being, but safety is very important. So, Isaac Asimov's robot, he invented this law, the 3 laws of robotics. So robot must not injure a human being or blah, blah. So it's a very important principle, maybe you know already. So the issue in the AI in the healthcare now is a WHO announced a kind of ethical principle of AI in the healthcare, 2 years ago. The most important thing first is autonomy, but this is more important technically to ensuring transparency, explainability, and intelligibility. So not only between the developers and the regulators, but also the medical professional and patients affected by it. So it's very critical task, So we need to have a explainable. Not now. It's changed to the explainability into the interpretability. So it's more accurate term. So what does it mean? The explainability or interpretability. So this is a very critical issue in the military use of AI or healthcare AI. So we need to develop trusted AI. It means that in a convolutional neural network, we don't know what's happening inside. It means that if some bad thing happens, it cannot be explained by current AI. It's a big problem, right? So these engineers now developing, very, the other side, kind of working to develop this interpretable or explainable AI. So it's a very interesting. So this kind of components clinicians need to explainability is clinically relevant or transparent or performance clarity or real efficacy or those kind of things. You may understand very well, but this was already published in 2019. So in the European Union, also they made a general data protection regulation. They also, very much stressing on the fairness, transparency, and explainability. So we will find that this term of explainability or interpretability in the current AI issue is making those kind of trusted AI. So trusted or trustable AI or trustworthy AI include a valid AI, responsible AI, or privacy-preserving AI, or explainable AI, somewhat similar or somewhat areas, but some different meanings for each. So it means that in anything So it's very important thing is to validate the high level of validation and accuracy reliability is needed to apply for the healthcare. So AI should be a decision support. It's not decision maker. It means that autonomy wise. I mean, the AI shouldn't have an autonomy. Robots shouldn't have autonomy. The doctors or healthcare professionals should control everything, supervise everything. Otherwise, it can be very harmful. It's a kind of just first principle. Anyway, I think we need to rediscover the surgeon's role in these days. I think, the surgical innovation is our role. It's a American Journal of Surgery, and it was someone, insisted that, so development of cost-effective solutions for daily surgical problems can be done with a kind of surgical innovation. And so future surgeons, I think, should be a digital leader and then multidisciplinary collaborator and data-driven decision maker. So super communicator. So not only doing just a surgery or just a minimally invasive surgery, laparoscopic surgery, but maybe we should have some interest for this issue and then look for some what's going on for these areas. So collaboration, I think, is a key for the innovation in the future, much more than the past. In the future, I think collaboration is very important. And otherwise, we cannot achieve the goals. Those kind of technology could help for the patients to have a benefit. So, okay, so I will summarize because the time is up already. So ethical issue is a very important. So there are so many biases. So there could be overly optimistic. So we need to be very careful, and because that innovation can be risky and then potential to harm. So we need to have a very balanced idea, and cost is also important. So surgeon's role is not just for the kind of liking those kind of new things, but also have some kind of responsibility for the evaluating the innovation and assessment of the evidence. So we need to have a very scientific mind to evaluate something new. It's very important, especially for the AI era, I think. Okay, that's it. So conclusion is the same thing I have talked to you. So thank you very much for your kind attention.
Now, the paper is open for discussion. My opinion, if we ask AI or robot to perform some part of our surgery, and complication occurs because of that, how patient feel, how we feel. If we do every procedure by ourselves, we feel sorry, very much sorry. But it's robots, not me. How we share the feeling of the patient and follow the patient.
Yeah, very core question. Yeah, very important question. For your question, have you read about the book Exhalation by Chang? The author, American author Chang, has wrote a book. He wrote a book about the scientific kind of fiction, and then he once answered about that question, similar kind of question to the kind of at the kind of, maybe it's a Financial Times. It's very famous newspaper, Financial Times, that I read, and he said AI is just an applied statistics. AI doesn't have any consciousness. AI is not a human being. So we cannot blame AI because AI is not any kind of human, those kind of existence. So every responsibility, every liability is for the surgeons. Yeah. So we shouldn't give any right to the, so that's the first principle of WHO announced 2 years ago. First thing, you shouldn't give any those kind of decision making to the AI. Yeah, it's just an applied statistics was defined by him. Yeah. Thank you.
Appreciation will be given to and Professor Ishigami come to the podium and taking a photo with the chairman. Thank you. Thank you, all speakers and Professor Sasako. And lastly, the Professor Young Kim, organizing chair of this forum, will give the closing remark, please.
Okay, thank you so much again. This forum was made by a lot of people's effort and an idea. Although we don't have a huge kind of audience like a lot of other meetings, but it must be very, very helpful for our internal staff of National Cancer Center. Could learn a lot of new things and then information, what's going on globally and then Japan. So it must be very helpful for our research or daily practice, and it must be helpful for the patient care, I believe. So thank you again for the participation, and then especially for the Japanese colleagues who coming over in this very cold weather. Thank you so much. And then I love to thank to Professor Chang-Yu Kim. Please stand up. Please give him applause. He's the head of the Center for Gastric Cancer, supporting this, forum very much. Thank you. And then Dr. Hong Man Yoon and the Young-Il Kim, today's my, master of the ceremony, MC. Thank you very much. And then Young-Soo Kim, she was a technical kind of secretary who prepared actually for everything. So huge kind of work was done by her. Please give him a big applause. And then our research nurses all participated. Thank you so much. And Suji Kim, and yeah, thank you. And then, okay, I don't want to forget someone who helped a lot, but everybody who contributed and then helped a lot, I really appreciate. And then we need to go to enjoy now, right? Well, we prepare the yakiniku is the Korean barbecue. It's a yangsumyeonok. So I hope you all join the dinner and then enjoy. Thank you so much.
Yes, actually, the bus is the standing on the bus stop on the slide. We are here currently location the cancer prevention and the early detection building, and then you go outside and to the lab, you can find the bus. So please, all speakers and all participants, please will attend and enjoy the meal. Thank you. We actually bus already the over there, but we have the 10 minutes, I think. 아니요, 버스는 벌써 왔답니다. We have the 10 minutes. Yeah, to go to the restaurant. 네네. 근데 너무 늦지 않을까요? 20분이나 기다려야 돼서. 근데 어떻게 여기 계시라고 할까요, 그러면? 1번 선생님들은? 이렇게 저희 그러면은 5시 반에 버스 출발하도록 그렇게 그러면 준비하겠습니다. 네네.